but important information.
Yes. So welcome to the Health and Government Operations Committee. Thank you for your flexibility. It has been a long day. The committee has been working hard for you. Please do not forward the Zoom link for the hearings. Staff not allowed anyone who was not invited to testify into the hearing. I ask you to encourage people to watch the hearing on YouTube. The Maryland General Assembly has its own channel. Bill sponsor witness timing is the following. The bill sponsor or a designee is allotted 5 minutes to present the bill. 5 witnesses will each be allowed to speak for 2 minutes in support. And please stay in the hearing until the delegates have had an opportunity to ask questions, because we will ask questions after the witnesses have testified. Next, 5 witnesses will each be allowed to speak for 2 minutes in opposition and then respond to questions. Please conclude your remarks when you hear the timer ring. Members must remain present with your video camera on so we can see you during the entirety of the hearing. Members, please ask only one question of one witness. If you have other questions, you may follow up offline. Please use the raise hand function to indicate that you have a question right there by the little icon, by the participant icon. And the bill hearing is the following. House Bill 484, House Bill 276, House Bill 463, House Bill 22, House Bill 108, and the last bill of the day, House Bill 29. We are going to start, members, with House Bill 484. Melissa and Jim, thank you so much for keeping us straight. House Bill 484 is Delegate Collison, Healthcare Facilities, Dialysis Treatment Services Training, the David Selby Dialysis Parity Act. Delegate Collison, good afternoon.
Thank you very much, Madam Vice Chair, Chairman Pendergrass, and members of the committee for the opportunity to present my first bill this year. And I think maybe I'll save you a little bit of time, because unless something's changed, there's no opposition to this bill. So we have a little bit of extra, we'll have a good start. This bill is in response to the need to assure the high standards of delivery of dialysis are consistent across all healthcare settings. You know, I didn't think dialysis was a surgical procedure. I thought it was more routine than that until this summer, when I had some, not me, but I know someone who had a personal experience with it and began to understand it's much more complicated than we thought. But the bottom line is the fact that get dialysis need it to survive. It's a serious medical procedure. It involves vascular ports or abdominal catheters that are used by people in a very vulnerable state, which is end-stage renal disease. In addition to the actual process, the risk of infection during the dialysis process is high. Given that, it's absolutely critical that we maintain high standards of training for those healthcare professionals who are responsible for performing and monitoring patients who are under this treatment. The reason for this bill is because the specific standards of care for individuals who receive dialysis is not consistent across healthcare settings, putting patients at risk. Simply put, just a little bit of medical knowledge, dialysis is the primary treatment for end-stage renal disease. The process filters toxins, waste, and fluid from the blood through a semi-permeable membrane. There are two kinds. One, I think many of us are familiar with, that's the hemodialysis, where people go to a kidney dialysis center or a hospital setting, and the blood is run through a machine and a filtering membrane called a dialyser. The second type is peritoneal dialysis and can be done at home with the family or caregiver support. Peritoneal dialysis uses an internal filtering agent to complete the process and can be, and in this modality, a bag of something called dialysate, which is about 2 quarts of liquid, is put into the peritoneal cavity through a catheter that's been surgically implanted. The dialysate has to stay there for 4 or 5 hours, then it's drained out and has to be thrown away. An important differentiation between the two modalities is the fact that dialysate stays in the body until it's drained. And if that's not done correctly, it will cause complications. The fiscal note refers to the training and certification that's required of staff at kidney dialysis centers in Maryland and in fact across the country. But in some instances, especially urgent situations, dialysis has to be done in other settings, such as hospitals or even private provider offices. In these cases, the individuals doing the dialysis are not required to have the same training, oversight, or regulation under Maryland law. In these instances, the procedure is called acute and therefore falls under the Joint Commission on Accreditation of Healthcare Organizations. But that's a general accreditation. And it doesn't include standards for outpatient dialysis. There is a special disease-specific care certification in end-stage renal disease, but to my knowledge, no hospital in Maryland has that certification. This bill seeks to require that the same level of standards for treatment in all settings so that these patients can feel confident that they will be safe. The standards for training and care already exist. They're there for the kidney dialysis centers, so we don't need to invent anything. There doesn't need to be a lot of thinking about this. There just needs to be the development of regulations to implement those standards in other settings. Turn whatever is left of my time to Elaine Selby, who is a constituent whose husband, unfortunately, was a victim of someone who did not have the knowledge in a hospital of how to deal with a patient who had been doing peritoneal dialysis. And so with that, I thank you very much for your consideration of the bill. And on behalf of all the patients who need dialysis, I respectfully request a favorable report.
Thank you so much. If I may ask those members that are not muted, will you be so kind and mute yourself? And next we have Ms. Elaine Selby. Ms. Selby, good afternoon.
Good afternoon, Madam Chair, members of the committee. My name is Elaine Selby. I am testifying today in support of House Bill 484, David Selby Dialysis Parity Act, and in memory of my husband, who would have been spared a painful ordeal had such a bill been previously enacted into law. It is with the hope that others may be spared a similar ordeal that I speak before you today. Regardless of the primary diagnosis requiring hospital admission for a kidney patient on dialysis, that patient must have his or her dialysis needs addressed by medical staff adequately trained in and experienced with the type of dialysis the patient is currently using. Of critical importance is the fact that in both therapies, hemodialysis and peritoneal dialysis, infection is the second most common cause of death. Unlike the dialysis centers, where the Centers for Medicare and Medicaid Services have established standards for the training and experience of nurses providing peritoneal dialysis services, there is no regulatory body overseeing the practice of inpatient peritoneal dialysis in the state of Maryland. Dave's peritoneal dialysis treatments in the hospital were performed by any one of several staff nurses assigned to his case. I began to question the adequacy of peritoneal dialysis training and experience among the staff after observing lapses in procedure during some of those treatments. I expressed my concerns. I knew the risks. Peritonitis, which is an infection of the abdominal lining, is a common complication of peritoneal dialysis. The risk of infection is greater if the person doing the dialysis isn't adequately trained. 26 days after admission, Dave was transferred to a Washington, D.C. hospital's critical care unit with peritonitis and in septic shock. Prognosis was poor. It was a difficult time.
You can take a few seconds to wrap up.
Oh, I had left out a section. I was going to say that Dave and I had been trained in performing home-based peritoneal dialysis treatments by dialysis center nurses who monitored his progress over more than 3 years. Treatment had been successful with no incidents of serious dialysis-related infection when he contracted pneumonia and was admitted to our local hospital's intensive care unit.
Thank you. And the committee is very sorry for your loss and for your experience. Thank you so much for being with us today.
Thank you.
Our pleasure. Next, we have Ms. Rhonda Scott. Ms. Scott, good afternoon.
I just realized I was on mute. Good
It's
afternoon, Madam Vice Chair and members
Good
of the
afternoon.
committee. Thank you for the opportunity to speak on behalf of the Board of Nursing in favor of House Bill 484. And the board has submitted its letter of support for this bill. And we just wanted to, add that the language in this bill is consistent with the training requirement in our COMAR Code of Ethics for both licensed nurses as well as certificate holders Code of Ethics. And in a lot of these treatment centers, it is often a certified nursing assistant that's a dialysis tech who may be performing the dialysis procedures, such as hooking them up or monitoring them. So we feel like, this is consistent with protecting the public through safe nursing practice, which is the board's mission. It just makes good sense to require an individual to be properly trained before performing any type of technical procedure such as this. So we're very pleased to support this bill, and we ask for those reasons that the committee please return a favorable vote. Thank you.
Our pleasure. Thank you for being with us today. And the last witness, oral witness for this bill is Ms. Karen Evans. Ms. Evans, good afternoon.
Good afternoon. Thank you, Madam Chair and committee members. Delegate Collison and Mrs. Shelby and Rhonda really stated all of the things that I wanted to say. But I just also want to highlight the importance of not just nurses, because I know we wrote that in our witness statement, but also the certificate holders is as critical as the nurses for education. So we just want to make sure, and Rhonda already gave our favorable, we're excited about this bill and also to support Delegate Collison. So thank you.
Thank you for being with us. Are there any questions for this panel? I see Delegate Hill. Delegate Hill.
Yes, thank you, Madam Chair, and
My
thank you, Delegate Collison. I think I understand what you're getting at, but I want to get some clarification. So peritoneal dialysis is often, very often performed at home by patients or their family members with relatively simple training on what to do. And I think your earlier witness testified that she and her husband have been doing it for a couple of years. It can also be done with and without a machine. So it can be as simple as hanging a bag, letting the fluid run in, putting the bag down and letting it run out over a few hours, or it can be done with a machine. Can you just clarify for me whether this would restrict people from doing peritoneal dialysis at home? Is this specific for using a machine or not a machine? Yeah, and you understand my question. I'm just trying to get an idea of who this.
It's really to make sure that all of the staff who are serving folks, no matter what kind of facility they're in, understand peritoneal dialysis as well as it's hemodialysis, right? Because in doing some research, we found this is something, there's the risk of infection with in acute settings, primary hospital settings, frankly, is higher for peritoneal than hemodialysis because it's just not as familiar. Less people use peritoneal dialysis than hemodialysis. So it wouldn't require a great deal of training because, it is something that can be done home, but the sensitivity to the infection rates and also in a conversation that I was having with Ms. Selby, she said part of the issue with Mr. Selby was the not understanding that the diacylate had to be removed. And so folks were not paying attention to that urgent need of having it drained out in his compromised position. He was not there because of end-stage renal disease, but for another reason. But they were not doing the peritoneal dialysis correctly.
Okay, and the training, is this, how broad, how much time is there for the training and what's entailed? Are we talking about sterile technique and just some, maybe Ms. Scott can answer that? What are we talking about? What
Miss,
kind of?
Ms. Scott, you have to unmute yourself. Yes.
I am. I was gonna ask if Ms. Evans could assist with that because it's been a long time since I've.
It's okay, Ms. Evans.
Yes, so the training isn't that long. What it will require is the didactic portion, the theory portion, and then a competency piece. And once they provide the competency piece, then they should be fine. So if you're asking about the number of hours, it should be at least maybe a 2 to 4 hour class, depending on what coverage, the information you're covering on it. And then to follow up with the skill set, that would be the person being competency on the skill. And then the next piece should be showing the competency to do a return demonstration on the actual patient to make sure that they've cleared that competency. So it doesn't take a long time at all.
So similar to basic life support, and so the facility itself could make sure that their staff are trained in it. They
Absolutely.
don't have to go off site to get the training or anything like that.
Correct.
Okay, thank you.
Okay.
You're welcome.
My pleasure. Thank you. I don't see any other questions for this panel or this bill. So this concludes the bill hearing on House Bill 484. Thank you so much, witnesses, for being with us today. Have a blessed day.
Thank you. You do as well. Thank you.
Thank you. Next, we have House Bill 276, which is Delegate Henson, and it's Congregate Care Facilities Visitation. Good afternoon, Delegate Henson, to the HGO Committee. She's coming in, the audio. Good afternoon.
Good afternoon.
How are you?
I'm well, Madam Vice Chair. Thank you for having me.
Wonderful. So we're ready to listen to you.
Thank you. Good afternoon, almost evening, members of the Health and Government Operations Committee. Thank you for your long hours and critical work you do for the state of Maryland every day. For the record, I am Shanika Henson, Delegate District 30A. I am here to present to you House Bill 276, Congregate Care Facilities Visitation, with the hopes of gaining your favorable report. The goal of this legislation, and pardon me, I just lost my screen. I'm gonna just minimize that. Thank you. The goal of this bill is to bring families together when they need it most, using alternative access by telephone or video, whichever is feasible. There's support for this bill and there's opposition too. A lot of work has gone into embracing solutions in the existing code and listening to care industries that simply aren't a good fit for a visitation law. If it pleases the committee, I have worked out several amendments with some of those groups that I would like to submit for the committee's consideration as well. But nothing less, I would like to start the conversation surrounding the need to find reasonable accommodations for those residents in care facilities and their need to stay connected with loved ones, even at the most difficult of times. I thank you for your consideration.
You're welcome. Next, we have we have Ms. Frances Smith. Ms. Smith, good afternoon. Are you here? Ms. Frances Smith?
Frances Smith has not joined us in the Zoom room. I sent her the link again about 10 minutes ago.
Okay, so we'll go on to the next witness, and as she comes, we'll give her an opportunity, delegate, okay?
Thank you.
Our pleasure. Next, we have Ms. Lauren Kalins. Amendment.
Thank you, Madam Vice Chair, members of the committee. I'm Lauren Callens. I'm here representing the Developmental Disabilities Coalition, and we are in support with what we believe to be 3 friendly amendments, which we've had an opportunity to share with the sponsor in advance. The Developmental Disabilities Coalition is comprised of 5 statewide organizations, all of us committed to improving opportunities and outcomes for Marylanders with intellectual and developmental disabilities, and all very committed to protecting the ability of the people we support to develop and maintain strong relationships with family and friends. As it has for so many providers, the COVID-19 pandemic has presented incredible challenges for the DDA licensed group homes that are included within this legislation, most of whom support people living in very small group home settings of 2 to 4 people. and all of whom have been forced to balance their statutory health and safety mandate against the desire for in-person visits. And there have been lots of creative ideas about how to make that happen, including rearranging furniture for in-home visits when that was possible, when the weather permitted. There were visits outside in backyards and front yards and patios of these group homes. And then the use of technology whenever possible when in-person visits were simply not safe. So we share the sponsor's desire to safeguard these visits, but respectfully request the following 3 amendments. The first would be to add close friends to the list of allowable visitors, as we support many people who don't have close family relationships, but who would benefit from a visit from someone close. Secondly, to add language that would reflect that a patient or a resident's desire not to see someone would be an acceptable basis for a facility's refusal to allow the visit. And finally, to strike the word particular on page 2, line 25. And the reason for this is that during an emergency, and we have certainly seen it play out that way by the COVID-19 pandemic, where many infected people were asymptomatic or didn't know they had been exposed, providers need flexibility. And our providers simply didn't have the resources to be able to do an individualized risk assessment for every potential visitor and every potential home for every potential resident. So with that, we respectfully offer our support with amendments, and thank you for the opportunity today.
Thank you for your testimony. Do we have Ms. Frances Smith yet? No? All right, so why don't we actually ask questions? Are there any questions of this panel that is favorable with amendment? I don't see any. Thank you so much for your testimony. Next, we're going to go to the unfavorable. We have Ms. Dana Kaufman. Good afternoon, Ms. Kaufman. Are you here?
Yes, I am.
You can get started.
Thank you very much. And for the record, my name is Dana Kaufman. I'm with the law firm of Schwartz, Metz & Wise. And I'm here on behalf of actually several clients that were included under the definition of congregate care facilities. I understand, or I thought I heard that Delegate Henson said that she had some amendments. I have not seen those amendments, but one of the issues that I did want to raise for the Maryland National Capital Home Care Association is that the congregate care facilities, the definition includes home care, or home health. Home health is actually a visitor in somebody's own home. They are not charged, they're not put in charge of visitation policies. So we would ask that if the bill were to move forward, that they would be removed from the bill. I think the other issue that on behalf of the assisted livings and the nursing homes and hospice, and you'll see the individual testimony, is that all 3 do have state and federal requirements for visitation. Pre-pandemic, visitation has never been an issue because it is a core resident right. There's very specific, and you can see it in the testimony for hospice. Hospice is a Medicare reimbursed service. So therefore, in order to participate in the Medicare program, you have to provide for, adhere to conditions of participation, which again, hospice, it's a core mission for them to bring families together. And during the COVID-19 pandemic, visitation was not restricted. The same goes for assisted livings and nursing homes. Prior to the pandemic, visitation is a core right, and there were already specific federal laws on the books and state laws. During the pandemic, however, those laws were superseded by not only the Secretary's directives on visitation, but based on CMS requirements, especially for the nursing homes. We are a federally regulated program, so we must follow CMS requirements. I can say that our members shared the frustration that so many families had and continue to have regarding visitation. And I am more than happy to go through what some of those restrictions were to give you a better understanding. But at this time, we are concerned that the bill is duplicative of existing requirements that pre-pandemic were not a systemic issue. The frustration that so many families had and continue to have.
If I can you please, please mute yourself if you're not speaking? Thank you. Thank you for your testimony. So next we have Mr. Aaron Greenfield.
Good afternoon, Madam Vice Chair, members of the committee, Madam Chairman. Aaron Greenfield here on behalf of Leading Age Maryland. You're going to hear very similar testimony to Ms. Kaufman. We're here unfavorable on House Bill 276, although haven't yet seen the amendments, and I look forward to seeing them. We appreciate the sponsor's intent, and social connection is vital, and our members work to facilitate connection through technology and, when possible, certainly in-person visits. As Ms. Kaufman has iterated, during non-COVID times, there are ample opportunities and support for in-person visitation. Certainly, there are these existing regs that inform a provider to ensure that the residents' rights are being met. During a pandemic, though, this bill, of course, fails to take into account the complex nature of infection control, existing visitation restrictions, guidance from CMS and the Department of Health. There are legitimate reasons for a provider to limit family visits, and we need to maintain that flexibility in accordance with the existing regs. And for those reasons, we respectfully request an unfavorable report.
Are there any questions of this panel? I don't see any. Actually, yes, Delegate Krebs, followed by Delegate Hill. Delegate Krebs.
Oh, how are you? Thank you. And either Dana or Aaron, someone can answer this question. Obviously, this bill sponsor has brought up a problem that exists for many of us. And we know that it's a problem. It's extending almost into a year now. And to me, it's just cruel and inhumane what we've done to some of our seniors. However, I understand you keep going back to federal guidance and the pandemic. But the question becomes, when does that end? At what point does your residents' rights have been stopped for a certain amount of time, but it's gone into a year now. So how would we approach this? We believe there's a problem needs to be solved. If not this bill, how do we ensure that our loved ones don't pass, with all this time passing without seeing their families for a year? So how do we rein it in? And would we have to go to the feds what's your suggestion on helping to move in the right direction on this? Because it is a problem.
Right. And if I may answer.
Absolutely. One person can answer. Go ahead.
Sure. And again, we share your frustration, and it really is going to be a situation where not only would you have to go to the Secretary of Health, who is operating under governor's orders, but for the nursing homes, it really is CMS. So not to go too much into detail, but it was CMS who on March 13th basically shut down visitation. And then in June, they started to reopen, but they did it with a metrics that was very difficult for homes to meet. For example, in order to allow indoor visitation, that home had to be infection-free for 42 days. And when I say infection-free, you could not have one positive case. So like we have examples of a part-time dishwasher, no contact with residents, no contact with staff, closed the facility down for 42 days. It wasn't even the 14 days of like an isolation or quarantine. You had to go back. And then October 1st, CMS launched additional, or it was September 17th, Maryland adopted it on October 1st, which allowed for the a little bit more opening because the numbers were going down. Unfortunately, then very shortly after, the numbers skyrocketed. The state applied those same guidelines to assisted living communities as well. So at the end of the day, we, the nursing home and the assisted living industry, are required to comply with those or face civil money penalties and other, I think it was a $5,000 penalty. So really the first step is to go back to the secretary to see if there's flexibility in changing those guidelines. And in the future, whether or not there could be greater consideration on the mental health status of the residents. I think that this pandemic focused very much, and I can completely understand why, on the physical health of the residents, but as it has gone on for almost a year, the mental health has just been so hard for so many to watch.
Thank you. I just wanted the committee, I think this is something we need to focus on finding a solution. whether it's this bill or not something else, is something very important that we, for the future, we need to help find a solution to. Thank you.
Well, I think, and I was gonna say it at the end, I know Delegate Lehman also has a bill similar. And so this is a problem, and I would encourage Dana and the others to please meet with Delegate Henson and look at what those amendments are. Next, for questions, we have Delegate Hill, followed by Delegate Lewis Young. Delegate Hill.
Yes, thank you very much. Thank you. So again, question is either for Dana or Aaron. So I hear exactly what you're saying because the bill is written and I don't know the sponsor's amendments. It's all about shall and would, right? And there's only one determinant, and that's that the facility has to determine that the patient or another resident will be harmed on a health level, which they can't determine when they don't know. But what about the last part? What about the part that says, if a congregate care facility determines that an in-person visit would, I mean, that might is not even there, but would endanger the health and safety of a patient, that the facility shall allow for an alternative means of communication. Where are you all on that piece of the bill?
Aaron, can I?
Yeah, I mean, you know, it is one that we would certainly support. However, again, it puts us in a really tough position between, you know, the family member and the resident. But generally speaking, I think it's something we'd certainly look favorably on. That provision, I think, helps the bill a little bit, but it does present these issues of us, which we had to deal with constantly. Our members did throughout this pandemic in making these.
So if that were all that were left of the bill, I'm not saying that softens the first part, because that first part doesn't give you any room. And even with the amendments that we've heard, I'm asking if that were the only thing.
Dana,
I think you would have to make it not a mandate, though, because right now it is a mandate that you provide the audio. And I think the facilities would need a little bit more leeway on what that would mean.
Hold on one second.
There are also issues.
1 second, Dana. 1 second. Delegate Rosenberg, will you be so kind and please mute yourself? And just a friendly reminder, it's okay, it happens. A friendly reminder for our members, will you please make sure that you're muted? Thank you so much. Dana, I'm so sorry. You may continue.
No, that's fine. Happens to us all. I think it is something that the communities did strive to meet. I think during the pandemic, there were two issues. One, there was just such a shortage of healthcare workers that it really became more of the time management of ensuring that the day-to-day health needs were being met and trying to balance the opportunity to allow residents to use the audio or, you know, FaceTime and different Skype. So I think if there's discretion or best efforts, kind of that language, it does help. And I will say that on behalf of Lifespan, and I think Leading Age did it as well, you know, we actually applied for a couple different grants. We applied for a grant from Care First. We applied for a grant from the Office of Healthcare Quality to purchase iPads so we could give them out to communities. Unfortunately, we didn't get either grant, but, you know, just trying to make that an option for families. So it was something we were very cognizant of.
Thank you.
Thank you. We have next Delegate Lewis Young.
Thank you, Madam Chair. I'll direct my question either to Ms. Kaufman or Mr. Greenfield. As you are well aware, I think Ms. Kaufman said in September, CMS updated their guidelines for compassionate care visitation. But at least in long-term care industry, they were interpreted very differently. In one facility, you had to be within 2 weeks of death to qualify for compassionate care. And in a facility next door, it could mean that your mental health was at risk. How can the industry more uniformly interpret and enforce those guidelines so that we don't have to have so many bills on this issue?
Well, I think, again, just to go back, because I want to make sure that we're not losing this point. Pre-pandemic, visitation has never been a systemic issue because it is built into being a resident right that has very little limitations on it. So please remember that. And this bill would affect regardless of time. It would be 365 days, pandemic, no pandemic. So that was our main concern, that we already have requirements on visitation and you don't want to address an issue in law that's already been addressed. Now, as far as, I forgot the question.
How could the industry more?
Oh, compassionate care.
Yeah.
For a compassionate care, I think you also kind of hit the nail on the head with a lot of this guidance. It was always very chaotic. It came out, at 5 o'clock on one day, and it was immediately effective. And there was very little discussion, very little interpretive guidance. So the facilities were really left to decide what that meant and to do it in a conservative manner. Because again, even though there was a reopening, there were different metrics that everyone fell under. So that was one issue, just because of how your community was as far as community transmission, positivity rates, your outbreak status. But I think that's something that we're really going to have to continue to have conversations about, because it really was the fact, like I said, that guidance came out and it was like, do it. But then it was trying to figure out, well, how to do it. What's it mean? And that was just a factor that was very difficult. So you're right. I mean, it did have an inconsistency about it, but I think it was the nature of how the guidance was being issued.
Thank you.
You're welcome. Any other questions? I don't see any. We do have the witness back, Ms. Frances Smith. I understand that she is now in the room. Ms. Smith, good afternoon. Ms. Smith, I see her. You have to unmute yourself, Ms. Smith. Ms. Frances Smith, I see you. You must unmute yourself and turn your video on.
I don't have a video on my phone.
Okay, that's fine. Good afternoon. May we have your testimonies, please?
Yes. Good afternoon, Chairman Pendergrass and Chairwoman Vice Pena-Mengnick. Thank you for the opportunity to address this Health and Government Operations Committee Bill 276. I'm Frances Smith, and on the 12th of June, 2018, my husband suffered a massive stroke. He was a dominant, commanding 30-year military officer, immediately becoming totally incapacitated. My husband of 55 years and my lifelong friend of 72 years was rendered dependent. Our roles instantly changed, and I became his protector and caregiver. We were blessed he was admitted in the Veterans Home in Charlotte Hall, and it became my home away from home. I spent at least 5 days a week with him, and we were surviving and living a new normal for us. I truly got to know the staff, and they truly got to know me. But on the 11th of March, COVID hit, and I was barred. For 7 months, I struggled to stay informed and communicate. I was truly thankful that the library opened and offered limited access for training that I so desperately needed. I established a Zoom account and coordinated with Charlotte Hall for reoccurring meetings. The Zoom meeting, the first one, the activities tech placed the headphones on my husband, and immediately we saw him responding to Judge Bell and myself. It was as if he was searching for us. We were shocked. It was so therapeutic, and I believe he knew we were there. I was so afraid he would think he was forgotten and lost. This bill is so very important to me because technology has advanced so quickly, and now with this pandemic unique environment, this need is critical and vital. I have a smartphone. I really don't fully use it. I have several master's degrees, but I am not technologically smarter than a fifth grader. This need is truly, truly essential for people like me. And you have the power and the ability to do a really great deed with this. Thank you very much.
And we're very sorry, Ms. Smith, of what you're experiencing, you and your family, and we really appreciate your testimony today. Are there any questions of this witness? Seeing none, I would like to tell the favorable with amendment to please meet with the sponsor, Delegate Henson, and see if you can meet and talk about it. I know that there are other bills similar that are coming as well, so the issue is not going to go away. Thank you so much for your testimony today on House Bill 276. And this concludes the bill hearing on House Bill 276. Thank you. Thank you so much. I know I myself forget sometimes to mute myself, so we have to remind ourselves. Next we have House Bill 463. And this is Delegate Barron and Delegate Jazz Lewis. Good afternoon, and it's Maryland Health Equity Resource Act. Good afternoon, Delegate Barron.
Good afternoon, Madam Chair and Madam Vice Chair and colleagues on the Health and Government Operations Committee. It's a pleasure to be with you this evening. Thank you for the opportunity to present House Bill 463, which would establish health equity resource communities and underserved communities to address poor health outcomes that contribute to health inequities. I'm proud to be joined on this bill by Delegate Jazz Lewis and many of our colleagues on a sponsor amendment. All Marylanders deserve access to high quality, affordable health care, but health inequities persist. In underserved areas of the state, people with chronic conditions have worse health outcomes and are less able to get care and treatment they need. The COVID-19 pandemic has further exposed these health inequities and highlighted the need to address them. The good news is we know that the concept in this bill works. It's based on a 4-year pilot championed by, among others, my constituent, Congressman Anthony Brown, when he was Lieutenant Governor. That pilot successfully increased access to health resources, improved residents' health, and reduced hospital admissions. It also created cost savings. We propose to invest in the program with a modest increase in revenue from alcohol beverage sales, which would also have additional healthcare benefits. I'm urging your favorable report. Thank you.
Thank you, Delegate. Next, we have Delegate Jazz Lewis.
Thank you, Chair Pendergrass, Vice Chair Pena-Melnick, and the members of the Health and Government Operations Committee.
You muted yourself, Delegate.
My apologies.
It happens. It's all right. It happens.
I know. How many Zoom meetings do we have to get this right? Thank you to the committee for your patience. I know the hour is late, so I will be brief. I appreciate your support and your patience and your ability to give this bill special attention. I want to thank the leadership of my district mate, Delegate Eric Barron and Senator Antonio Hayes for their work helping with this bill. Nationwide protests against racial injustice has highlighted systemic changes needed throughout society, including access to health. Data in our own state shows that COVID-19 crisis has hit racial and ethnic minorities uniquely hard. In Maryland, we've made a lot of progress over the last several years, but higher mortality rates persist for racial minorities and rural residents. Even within regions, large disparities exist. In my home county of Prince George's County, there's a 16-year life expectancy gap between Suitland and Greenbelt. This initiative, known as the Health Equity Resource Community Initiative, offers a targeted way to make sure support is reaching the areas that need it the most. Eligible communities will be able to compete for part of the HERC initiative by proposing ways to address the health needs of their underserved residents. Those selected will receive new grants and tax incentives to expand care. and healthcare providers working in those areas could become eligible to have their educational loans repaid, creating a valuable incentive for providers to practice in these areas. Over time, this initiative will pump major new funds into these previously underinvested communities, with high-functioning healthcare providers making sure all resources are spent effectively. Our goal is to wipe out the persistent healthcare disparities across the state, which harm people of color, people living in low-income neighborhoods, and people in rural areas. As my district mate stated, Congressman Brown, our constituent, had a successful pilot with the Health Enterprise Zone on this bill from 2013. And I think now is the time for us to pass this bill, move it from a pilot to a permanent thing that we move forward using. Thank you. I urge a favorable vote.
Thank you for your testimony today. Next, we have Representative Anthony Brown.
I'm in a hearing. So I've been in hearings since.
Thank you, Madam Vice Chair Pena Melnick. I want to thank you and the chairwoman, Pendergrass. I had an opportunity to serve with her many years ago on the Economic Matters Committee at the time when it also had healthcare in its jurisdiction. It is truly an honor and a privilege to testify before the House Committee on Health and Government Operations. And I do so in strong support of HB 461. I thank the sponsors, Delegates Lewis and Barron and others, my constituents. They work for me, I work for them. Together we work for our shared constituents. But I want to thank them for introducing the bill. And I want to thank the members of this committee for addressing health disparities as this bill does. Across the United States, infections, hospitalizations, and quality of care are disproportionately impacting Black and Brown communities. This is a systemic issue. The Maryland Health Equity Resource Act seeks to address this issue by creating a program modeled on the success of the Health Enterprise Zone pilot initiative that I launched as Lieutenant Governor in partnership with this committee. The program set out to reduce health disparities by increasing access to primary care while lowering healthcare costs and in-hospital stays. We designated 5 health enterprise zones, or HEZs, in rural, suburban, and urban areas across the state that were considered underserved by our healthcare system, including a zone in Capitol Heights in Prince George's County, one in Greater Lexington Park in St. Mary's County, downtown Annapolis, Dorchester and Caroline counties, and one in West Baltimore City. We recruited doctors and health workers to improve access to and promote healthier behaviors. And each zone's initiative was tailored to the needs of each community to meet the specific health priorities of each locale, such as mental and behavioral health, prenatal medicine, or primary care, and to improve care and health outcomes for seniors in hard-to-reach areas, food insecure children, low-income families, minority populations, and more. The initiative was led by collaborative partnerships between community-based organizations and the local health department or hospital. Through this innovative approach, the program and its administrators were able to address complex socioeconomic issues in those underserved areas. The results were a resounding success. According to a 2018 Johns Hopkins study published in Health Affairs, HEZ saw a decrease of more than 18,000 inpatient stays during the pilot program. This resulted in a savings of over $108 million in healthcare costs, far outweighing the $15 million cost to implement the program. And we were able to reinvest these dramatic savings back into our communities to further improve health outcomes. Unfortunately, this program was allowed to expire by Governor Hogan. Targeted programs like this initiative are efficient and can dramatically improve health outcomes in minority and underserved communities. That's why I introduced a bill similar to what you're looking at today in Congress to take this approach to a much larger scale. And my federal bill will do what you're looking at in this bill today and also combine market-based incentives with traditional federal resources so we can take Maryland's success and make it America's success. Justice and equity must extend throughout our communities, including our health care system. And in closing, let me say that I look forward to working with you in not only getting this bill passed, but implementing it, because only if we work together, the federal, state, and local level, will we really achieve better outcomes in health care in our communities. So I stand ready to work with each and every one of you. And I thank you, Chairwoman Pendergrass and Vice Chair Pena Melnick, for the ability, the privilege to testify today.
Thank you, Congressman, for your leadership and for your time. Next, we have Mr. Vincent DeMarco. Mr. DeMarco?
Thank you, Madam Chair, Madam Vice Chair. It's always a pleasure to be before this committee. Thanks to this committee, Maryland is one of the leaders in healthcare in our nation. The legislation you have helped enact has reduced the uninsured and expanded healthcare and made prescription drugs more affordable. But despite that, as you heard so eloquently from Delegates Barron and Lewis and Representative Brown, there are still dramatic health disparities in our state, which we need to address. We are thrilled to be strongly supportive of House Bill 463, and we are very, very proud that Speaker Adrian Jones has made this bill one of her, quote, black agenda bills that are part of her agenda. We believe it is very, very important, as do the vast majority of Marylanders who support this measure, as witnessed by over 280 faith, community, labor, business, and healthcare groups from around the state that have endorsed this. The bill has been endorsed by my own mayor, Brandon Scott of Baltimore, County Executives Johnny Olszewski, Calvin Ball, Stuart Pittman, Mark Elrick, and Angela also Brooks. It is broadly supported. We urge you, as you're thinking about this legislation, to remember that one thing the 2012 measure that Congressman Brown talked about did not have was a permanent funding mechanism. We think that is critical, a permanent dedicated funding mechanism to make this happen forever. We recommend a 1 penny increase in the state alcohol tax as the way to do that, because as Delegate Barron said, in addition to funding the program, it would continue this progress you made in the 2011 alcohol sales tax increase to decrease underage drinking and drunk driving. And as the data in our study shows from the ABLE report, it worked dramatically to do that and funded the health enterprise zones. So we urge you to enact House Bill 463 to recreate the successful health equity resource communities like the HEZs and create a permanent dedicated funding mechanism with the alcohol tax is what we recommend. Thank you very much for the leadership of this committee.
Thank you. Perfect time. Next, we have Ms. Victoria Bayless.
Thank you very much, Madam Chair and Vice Chair. I'm very pleased to be able to support House Bill 463, the Health Equity Resource Act. I am Tori Bayless, and I serve as the CEO for Luminous Health, which is a newly formed system operating in Anne Arundel, Prince George's counties, as well as across the Eastern Shore. And we are very supportive of this, as is the Maryland Hospital Association and its 60 member hospitals and health systems. Thank you to Congressman Brown for the reminder of all of the incredible work he did as our Lieutenant Governor on the health enterprise zones. I had the privilege of leading one of those in partnership here in Annapolis with the Housing Authority of the City of Annapolis, where we stood up a primary care clinic literally in the living room of the residents of a low-income apartment, the Morris Blum Senior Apartments. Luminous Health has been on a journey around health equity. We were recognized in 2019 as the American Hospital Association's Equity of Care winner. Only one hospital is recognized annually. And as I think about the efforts we've put forward and the work that we did specifically with Morris Blum from 2013 to 2016, it is a great success story. And the report from the School of Public Health at Johns Hopkins clearly stated the return on investment was remarkable. Unfortunately, though the return was significant, there has been some slowing of investment and really not taking these pilots up to scale where they could be replicated in multiple other communities due to the lack of ongoing funding. So we do want to see an ongoing steady source of funding for these types of programs. And again, ours was a primary care clinic. It reduced 911 calls, reduced ER visits, reduced hospitalizations, and had a very good ROI. So in order to scale that elsewhere in the regions that we serve, we would like to see continued funding, and we would be working in partnership with many different partners, community health workers, faith-based organizations, social service agencies, and the like. So I strongly urge you for a favorable report on House Bill 463. Thank you so much.
Thank you for being with us today. Next, we have Ms. Michelle Spencer.
Good afternoon, and thank you, Madam Chair, and members of the committee as well. I appreciate the opportunity to testify in favor of this important health equity legislation sponsored by Delegate Barron. My name is Michelle Spencer. I'm a faculty member at the Johns Hopkins Bloomberg School of Public Health, and Johns Hopkins is pleased to support this legislation. As you've heard, in some communities, neighborhoods within a 5-mile radius experience gaps in life expectancy up to 18 years, including neighborhoods in Baltimore City and Prince George's County. The General Assembly in 2012 passed Senate Bill 234, establishing the Health Enterprise Zone Initiative. You've heard that the goal of that initiative was to reduce health disparities among racial ethnic groups and geographic areas, improve health outcomes, and reduce healthcare costs and hospital admissions and readmissions. Analysis was conducted by my colleagues at Johns Hopkins and found that the HEZ was associated with a reduction in inpatient hospital stays, as well as over $93 million in savings to Maryland's healthcare system. All of the HEZs across the state expanded primary care services, and all did so with a focus and a commitment to community health. You have before you examples of what the HEZs were able to accomplish, including positive impacts in individual health behaviors, health outcomes, and cost reductions, testing and developing creative community-based solutions, and certainly addressing racial ethnic disparities. I'm pleased to stand with Senate Bill and support Senate Bill 463, that it builds on the 2012 legislation. The proposed 1 penny per dollar increase in the state alcohol tax will make sure that the Health Equity Resources Committee has the funding it needs to continue, and the added public health benefit of reducing underage drinking and drunk driving. This legislation builds on the experience and the evidence from the previous HEZ investments. I served as the director of the HEZ initiative at the state, and I am pleased to stand with Johns Hopkins University President Ron Daniels, President of Johns Hopkins Medicine, Kevin Sowers, Vinnie DeMarco, and many elected officials in supporting this bill, and I look forward to your favorable report. Thank you.
Thank you for your testimony. We appreciate it. Are there questions for these witnesses? One second. I see Delegate Lewis Young, followed by Delegate Charles, followed by Delegate Lewis. Delegate Lewis Young, please unmute yourself.
Thank you, Madam Chair, and thank you to the group of presenters that presented this important legislation. My question deals with the funding source, and it's a question I'm passing on from many, many constituents who have asked this question. It is about restaurants who have been inordinately negatively affected by the pandemic. They claim that alcohol is the main source of their profit. And although this bill has a delay, they don't see that they will recover from their losses from the pandemic in that time frame. So my question is, have you considered either a more diversified funding stream from other industries or products that have negative health outcomes, or perhaps a delay in the implementation date?
Madam Chair, I'll address that if that's okay with the rest of the panel. I think that the 2-year delay that's in the bill for bars and restaurants is very much put in there to deal with the COVID issue. If they want to propose a longer delay, we'd be happy to discuss that. The fact of the matter is that the 1 penny increase in the alcohol sales tax would not adversely affect the alcohol industry. In my testimony is data showing that after in 2011, the legislature enacted a 3-cent increase in the state alcohol tax, the revenue from that tax kept going up and up and up every year. And we know that outside bars and restaurants, liquor stores are doing very well in their sales. The 1 penny will not hurt the alcohol industry, but it will reduce underage drinking and drunk driving. The ABLE study, which is in our report, shows very clearly that kids will drink less and people who shouldn't be drinking more, drunk drivers, will drink less, and we will save lives. So you will save lives, you will not hurt the alcohol industry, and most importantly, Delegate, this proposal has a dedicated permanent funding mechanism for the health equity resource communities, which I think is the most critical aspect of it. We know that $14 million a year will come in the first year, $1 million dedicated to behavioral health around the state, and the rest, the health equity resource communities. And after that, $22 million. But we certainly would be open to an extension of the delay on bars and restaurants.
Thank you for that answer. And could you send us all a copy of that study?
It's in my testimony.
Oh, sorry, I didn't see it.
I'm sorry, but in my testimony is the ABLE report showing, and I want to thank you, in 2011, you increased the alcohol tax from 6 cents to 9 cents, and you picked 9 cents because that's what DC was at the time. Since then, DC has gone to 10 cents, using that extra penny for healthcare. So this would be continuing what you started in 2011 with a lot of success.
Thank you. Thank you, Madam Chair.
Wonderful. Next, I have 1 minute. I'm sorry, my internet is a little unstable. Next, I have Delegate Charles.
Thank you, Madam Chair. This question is for my Congressman Brown. Can you do me a favor and expand on how successful the health enterprise were and how the pilot legislation came about?
Sure. And first of all, thank you for representing District 25, and it's a pleasure working with you. The focus at the time, as it is today, is to look at health disparities and what causes these health disparities. And we saw while there are many determinants, one of them was that just a lack of primary care resources in these communities. So as you do regularly, when you have great ideas in Annapolis, and you're not sure whether or not your idea is going to actually translate into results, you pilot it. So we said, hey, that makes sense. Let's pilot it on a small scale. We'll do 5 zones. They were sort of geographically diverse, ethnically, racially diverse. We insisted that it has to be community-based, the community working with an anchor health institution or a local health department would bring together partners, identify what the disparity is that they wanted to focus on, knowing that you can't do everything with limited resources. And that's how we decided to do it, to pilot it, and not just to create a program that would go statewide. And as you've heard, Hopkins studied it and the results came out. It's been a resounding success. So I'm taking this pilot that Maryland successfully implemented. I've introduced the bill at the federal level. So I think we should take this to communities from Iowa and California to Maine and work with Maryland so that your investments can go even further. So that's kind of how we decided to pilot it before we went full blown. Based on the successes, I was very disappointed that Maryland did not expand the program, instead let it sunset.
Thank you, Congressman.
Okay, next we have Delegate Lewis, followed by Delegate Kipke. Delegate Lewis.
Thank you, Madam Chair. I want to thank Delegate Barron, Delegate Lewis for bringing forward this great bill. Thank you, Congressman Brown, for your past work. You gave us something to build on. I'm curious to know, and of course the advocates, thank you, Mr. DeMarco. I am curious to know whether the Health Equity Resource Fund can be used by local health departments. The reason I ask is that we know in Maryland for over a decade, we have consistently underfunded local health departments to the point where they are now not well equipped to respond really strongly to some of our COVID challenges. So if you could let me know that, if health departments can benefit from being designated, that would be great. Whoever's best equipped to answer.
So I can speak to, thank you, Delegate Lewis. I can speak to that from the perspective of what we were able to do with the HEZ legislation. The fund, the $16 million that was designated for the HEZs, local health departments received funding through that. They were, if you applied and you were qualified and you were designated as one of the HEZs, of which Prince George's Health Department as well as Caroline Dorchester Health Departments were eligible for that and did receive funded and were funded. And so they were able to use some of those dollars in support of implementing the HEZ program in those specific communities.
And did the designation of a local health department affect the ability of other community-based groups to also be designated?
No. And so, I'm sorry, Delegate Lewis, thank you for your question. No, specifically, local health department, that designation did not disallow any other organization to qualify. As a matter of fact, a local health department or a health system needed to be the anchor institutions for which community-based organizations were working and would be receiving some funding to implement HEZs within their specific
So it's like
areas.
building strength to strength.
Absolutely.
Great. Thank you, Ms. Spencer. Thanks so much, Madam Chair.
Can I just also note—
My pleasure. Delegate Kipke.
Madam Vice Chair.
Delegate Kipke.
Thank you, Madam Chairman.
Yes.
My question is for Dr. DeMarco. You had mentioned in your comments that the alcohol industry is doing quite well. And while I would agree with you that liquor stores have probably done pretty well during the pandemic, I see some of you shaking your heads. Obviously, breweries, wineries, restaurants, nightclubs, bars, they're on life support for obvious reasons. And my question to you, Mr. DeMarco, is after we raised the sales tax on alcohol the last time, are you aware that the sale of those products declined at a significant clip for the next 18 months after that sales tax increase was put in place?
First of all, Delegate, thank you for the promotion of doctor. I appreciate that. No,
I think very highly of you.
Well, it's mutual. It's mutual. Great working with you. Well, what I know is from the data that you could see in my testimony over the few years after the 3 cents was instituted by the legislature, revenue from the sales tax kept going up and up and up. And that indicated to me that it didn't really hurt the industry. And a 1 cent would be, of course, even less impact on the overall industry. But it does, as the ABLE study shows, reduce underage drinking and drunk driving. And again, we recognize right away, bars and restaurants are hurting. And there is a 2-year delay in the bill. And from what you and what Delegate Lewis Young have said, if the restaurants and bars need that to be longer, we could certainly discuss that. But I just want to reemphasize our major point that what you've heard today is the absolute need for health equity resource communities, and to build on what Congressman Brown and others succeeded, and Michelle Spencer and others succeeded, and it needs a permanent, dedicated funding source. We believe the alcohol sales tax is the best way.
Okay, thank you. Thank you, Madam Chair.
Thank you.
My pleasure. Delegate Young.
Thank you, Madam Vice Chair, and thank you, Delegate Lewis and Delegate Barron for bringing the bill. I really don't have a question on the merit of the bill. It's once again the funding mechanism as well. And my question for Mr. DeMarco is, because you've said it twice now, well, it's only a penny, and I'm confused on if it's only a penny, how does it discourage underage drinking and underage driving? If it's just a penny, as if it's just a penny, but it doesn't really have any correlation to decreasing the underage driving unless there's something I'm missing. Is it much more than a penny?
It's a good question, Delegate, and I appreciate it. It is just a penny. That's all we're proposing. The 2011 sales tax increase was 3 pennies. And the ABLE study shows that it did reduce underage drinking and drunk driving without affecting the overall industry, because the 3 pennies add up if somebody's drinking too much, or if someone is a youth who can't afford to put even several more pennies up on something. So the fact of the matter is, and there's an analysis by Professor David Jernigan of Boston University showing how the 1 penny would not save as many lives as a 3 penny, but it would save some. When you add it up, if someone's a drunk driver or going to be a drunk driver because they're drinking too much or they're a youth, it adds up for them. It doesn't affect the overall industry, but it has a targeted effect where we want it on underage drinking and drunk driving. I encourage you to look at the ABLE study, and I'm happy to discuss that with you after you do, but that will explain very well how this will have an impact.
Thank you, Mr. DeMarco.
We have Delegate Shalega, followed by Delegate Krebs.
Thank you, Madam Chair. And this question would be for Dr. DeMarco, I guess we're calling you now. You mentioned in your previous testimony that you would be willing to put this off for beyond, I think the bill says 2023. So if that's the case, hi there. Sorry, we have a pop-in visitor. If that is the case, why would you be opposed to just putting this off for another year? We're really trying to focus on COVID relief, the 3-penny increase, all of that's going to the general fund, potentially carving some of that out now without raising taxes and put this tax increase off to next year or the year after.
Well, Delegate, I'd have to defer to our lead sponsors on issues like that. All I'm saying is, from our perspective, the delay for bars and restaurants, we thought that 2 years would deal with the COVID issue. If the bars and restaurants would like that part of it delayed more, I'd defer to Delegate Barron and Delegate Lewis, but we wouldn't object. The initial tax on the liquor stores outside of bars and restaurants, we would urge that start now in order to begin the 14 million to create these programs and get the permanent dedicated funding source. Once again, I want to emphasize, for all of us, the most important goal is the permanent dedicated funding source to make sure that these programs can reduce health disparities. And I'm thrilled by what seems like the general consensus that that's going to happen. And I hope that we could work together to create that permanent dedicated funding source. Thank you, Delegate.
Next, we have Delegate Krebs.
Thank you, Madam Chair. And Dr. Vinnie DeMarco, I don't know where you're finding your drinks for $1, because a penny on a drink is $1 drink, and I haven't had a $1 drink ever in my life. But anyway, it is a percentage; it's not a penny. But back when we did the tax, some voted for the tax increase back a few years ago. It was supposed to be a dime a drink for the disabled. And the disability community walked around the halls of this beautiful building for a couple of years, pushing for a dime a drink. And that's all it would cost. And we have all this money for the developmentally disabled. And we haven't seen that. They're still looking for their resources. So how, I get the question is, right now we're looking at a specific tax. It's basically, you talked about DC, but you didn't talk about Virginia at 5.3, Pennsylvania at 6, West Virginia at 6, and Delaware at 0. And I can tell you the bars and restaurants in Ocean City, especially the retail stores, are not doing too well when they're competing with a 9% differential just going up the street. So I guess why was it chosen to pick this particular industry to continue to barrage with taxes and not something else? They're already paying over 50% more than any other industry in taxes. So why this industry, and where does it end?
All right, Delegate, thank you. First of all, I think it's important to go back to 2011. In 2011, you passed a 3-cent increase, which raised $70 million a year. And then, led by, I think, the House of Delegates, the money went the first year almost all to school construction, to which we did not object. And after that, $5 million a year for development disabilities. And the rest going into the general fund. We worked closely with then Secretary of Health, Josh Sharfstein, to make sure that the $70 million through the regular budget process went into the public health needs, including development disability, mental health, drug and alcohol prevention. That was our original goal. And that happened through the regular budget process. And I was assured in 2015 under the Hogan administration that it was continuing to do that. So what you accomplished in 2011 was a drop in underage drinking and drunk driving and $70 million going to public health. And again, I want to emphasize our goal here is a permanent dedicated funding source for the health equity resource communities. That's our goal. We believe that a best way to do that is this 1 penny increase in the alcohol sales tax because of the additional public health benefits as laid out in the ABLE report. And I want to congratulate you again for what you accomplished with the 2011 alcohol sales tax. And I want to emphasize that some of the money from the alcohol sales tax of 2011 through the health department, through Josh Sharfstein, was put into the health enterprise zones. So the health enterprise zones back then were also funded indirectly from the alcohol sales tax increase.
Thank you. We have next Delegate Riley.
Thank you, Madam Chair. Yes, my question also goes to Dr. DeMarco. You keep repeating yourself that you feel that this will not hurt our restaurant and bars, the industry. And so my question to you, I mean, I can go through our opposition letters and there's quite a few of those. So other people think differently. So my question to you is, do you own a bar or restaurant?
I do not.
Okay, thank you very much.
Thank you. Any other questions for this panel? I don't see any. So thank you so much for your testimony today. Next, we have a panel of favorable with amendment. We have Ms. Allison Taylor. Ms. Taylor.
Hi, good afternoon, Madam Vice Chair, members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente in support of this legislation. We're requesting an amendment to expand the scope of the advisory council to include representation from the payer community. And part of that is because Kaiser Permanente was involved with the HEZ program during its first iteration, and we'd like to remain involved one way or another in this initiative once it's enacted. You've heard from some of the other witnesses about the strong policy reasons for supporting this, and we certainly support that as well. The other thing I wanted to flag and just reinforce is this program is backed by strong evidence, a study done by Johns Hopkins, as Ms. Spencer noted in her testimony, and it also builds into the legislation the requirement for ongoing evaluation of this program. So I know you all are faced all the time with a lot of competing proposals to look at, but you know, whenever you see something that's going to be continually evaluated, I think that that's a really good bet. So that's another reason why we support this. On a personal note, I was at the health department during the HEZ initiative, and it was an honor to work on it then. I was really pleased to see this come up again this year, and I urge a favorable report. Thank you.
Thank you for your testimony today. We have next Mr. Matthew Celentano, favorable with amendment. Mr. Celentano.
Good evening, members of the HGO Committee and Vice Chair Pena Melnick. My name is Matt Celentano. Today, on behalf of the League of Life and Health Insurers of Maryland, consisting of Aetna, Care First, Cigna, Kaiser Permanente, and United Healthcare. Also here on behalf of America's Health Insurance Plans, or AHIP. We are here today favorable with amendment on House Bill 463. I will not repeat the great recap by Congressman Brown and my main man, Vinnie DeMarco, but I would like to reiterate the support from the League, who is committed to making sure we improve health outcomes and address health disparities. We believe that House Bill 463 would enhance the successes of the 2012 through 2016 health enterprise zones through collaborations with local health departments, hospitals, and community-based organizations. These health and equity resource communities can build upon past experience and best practices to transform healthcare for Marylanders in need. We would respectfully request that a member of the insurer community, the nonprofit health service plan community, and a health maintenance organization be added to the advisory committee and are in full support of the bill. Thank you very much.
Questions for this panel? We have Delegate Kipke. Is your hand still up or?
Yes, I can't avoid.
Delegate Kipke.
Thank you, Madam Chair. I can't not ask Mr. Celentano a question. I don't yet call him Dr. Celentano, but we all feel like one spending time on this committee. I think it's interesting that there's so much desire to raise another tax in Maryland when we're already one of the highest tax states in the nation. While this is a very valuable and necessary and, as the congressman put in, an exciting thing, a lot of good progress do you not have any concern, Mr. Celentano, that, piling on another tax like this might not be good for Maryland's economy, Maryland's small businesses, and may actually produce some other side effects? I think about businesses in Ocean City, for example. I know a lot of people who drive to Delaware to buy their beer and wine to avoid the taxes, the heavy hand of taxation in Maryland. And Mr. Celentano, since, I think of you sort of like an economist, I was hoping that you might be able to provide some insight on that.
Well, Delegate Kipke, Dr. Celentano would be my dad, the epidemiologist who certainly had his time to shine in the last year. I am no doctor, but I will say that the league and the member companies are sort of agnostic about the tax. But if you are going to have to increase a tax, which I think the league companies would say that we're really never going to be in support of, it should be a public health measure like an alcohol tax, which when used improperly, alcohol can create a lot of negative healthcare outcomes. And if used in moderation, it's certainly okay. But if we're going to address health disparities, we're going to have to find some funding. And these kinds of public health revenue measures are probably the best way to address this particular program. And it would be a long-term solution to make sure that we continue to fight the challenges that have existed for decades.
Thank you. And since we already have one of the highest taxes on alcohol in the region, maybe we should think about chips and soda. But anyway, thanks for playing along with me. I'm feeling a little spunky this afternoon.
I will defer to Dr.
All right, let's take to the question. Let's ask the question, okay? We still have more bills on the agenda. Any questions for this panel? Seeing none, thank you very much. We have a panel. We have a panel of unfavorable. We have Mr. Terry Laughlin.
Yes, thank you to all the committee chairman and vice chair and all the committee members. My name is Terry Laughlin. I'm the vice president and general manager of Carey Distributors on the Eastern Shore of Maryland. We service over 500 on and off premise bars, restaurants, taverns, liquor stores in Worcester, Wycomico, and Somerset counties. I heard the reference that Ocean City people are leaving and driving to Delaware. That is absolutely the truth. Back in 2011 and 2012 timeframe, when the alcohol tax went from 6% to 9%, I can tell you our business declined. We were down 3.1%, and we were the customers that particularly were hurt were those on the Delaware border. I don't know if you can see this billboard behind me, this picture of a billboard. I can't tell if it's flipped or not. That billboard is located in Maryland, and it says tax-free liquors. It's directing Maryland consumers to drive 1 mile across the border to Delaware to purchase tax-free beer, wine, and alcohol. We can only assume that this is obviously a big financial win for the retailer. His name of his liquor store is Tax-Free Liquor. He pays over $2,000 a month for this billboard to keep it in place, and it's been in place since 2012 and is still there to this date. The Ocean City situation is even a little worse. There's a 0.5% sales tax on alcohol that was passed to fund principal and interest on bonds to fund the Ocean City Convention Center. So not only is it a 9% sales tax on alcohol, but in Ocean City, it's a 9.5%. And we bordered Fenwick Island, Delaware. So we do have plenty of people that are leaving our territory. So I guess let us be clear. We support the efforts to tackle health disparities, but we don't think it should be on the back of alcohol. And we certainly don't need any more billboards like this in our market. Thank you.
Thank you for being with us today. We have next Mr. Jack Milani.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. Jack Milani, Maryland State Licensed Beverage Association.
I want to echo what Mr. Loughlin said. We certainly support the concept. We just think that we are not the source for the funding. Mr. DeMarco is correct. When we went from 6 to 9%, we did raise about $76 million. And I know in 2019, it was up to $103,548,000. So we felt like, we made the deal with President Miller and Chairman Casemeyer that instead of an excise tax, and let me explain, an excise tax is tax on the actual gallonage. That's been flat for the last 10 years. The reason we have an increase on the sales tax is because it was designed so that every time there was a price increase, the state got a raise. We agreed to that because we figured, okay, we'll take the sales tax. Every year the state gets a raise. We won't come back to this issue. That's how it was sold to us, and we went along with it. So I think our industry has certainly been used to fund a lot of things, but to me, $103 million additional, that's not including the 6%, not including the $30 million on the excise tax, which, just on a side note, that $30 million gets taxed at 9%. So you collect about $2.8 million tax in the tax. And at some point in time, I think, this is too important to have these type of hearings. This should be in the general fund. I think we would all support that. But, we talk about the restaurants. Well, a lot of folks realize, or I hope they realize, and they're supporting them with carry out alcohol sales. That's not going to be held off. That's an off-premise sale. That's going to be subject immediately to the tax increase. So, this is just the wrong time to even have this discussion. And for that reason, we're going to urge an unfavorable report. Thank you.
Thank you for your testimony. We have Ms. Sarah Hilly. Ms. Hilly?
Hi there. Good evening, Madam Vice Chair, members of the committee. Can you hear me? Okay. My name is Sarah Healy. I'm the president of the Brewers Association of Maryland. I'm here representing the 275 small businesses that are members of the Brewers Association of Maryland, the Maryland Distillers Guild, and the Maryland Wineries Association. My testimony today solely relates to our collective opposition to the tax increase proposed in House Bill 463. We recognize that the objectives of the bill are to address important societal goals. However, House Bill 463 does not share the burden of meeting these societal goals across all of Maryland. It instead focuses disproportionately on our small businesses, which are all in an historic struggle to survive. Our businesses are not large international conglomerates which market products worldwide. Actually, only one of the 275 members of the 3 organizations I represent here tonight started outside of the state of Maryland. These businesses represent exactly what we want to see in Maryland, which is Marylanders hiring Marylanders to manufacture and sell locally made products right here in our state. As I'm sure this committee is aware, our product is taxed twice by the state at production and sale. Predominantly, these taxes are paid by us at the time of manufacture, often before we know we even have a customer. This is different than almost any other consumer product on which sales tax is paid. This double tax burden is in addition to the facts that the sales tax on alcohol is the highest rate of any other consumer product. As you know, the effect of COVID-19 has been nothing short of devastating for all small businesses. Nearly all of our 275 members rely on Marylanders visiting our locations to buy our product. This dynamic unfortunately changed in March as we closed our doors to visitors, only to have many consumers shy away from visits even when they could return in a limited way. This effect has been profound, and all of our small businesses will feel the impact of COVID for years to come. So as you take a look at the tax provisions of House Bill 463, please remember that they fall equally on a marketplace that is very unequal. Maryland wine accounts for only 3% of wine consumed in the state. Maryland beer accounts for less than 10% of all in-state beer sold, and Maryland distilled products are below 1% of the consumption in Maryland. Yet the new tax burden—
You have to wrap up, please. Please start to wrap up. Thank you.
For these reasons, we respectfully ask that this committee revisit the tax portions of House Bill 463. Thank you.
Thank you so much for your testimony. Are there any questions for this panel? I see Delegate Shalega. Or was that your hand from a prior question?
No, it's my handy. Thank you, Madam
My
Chair.
pleasure.
I appreciate you all being here, and my question will be directed to Jack Milani. Jack, it's my understanding that you own a carryout, not just a bar and restaurant, but also a packaged goods store.
Yes, that's correct.
And would you describe the people that come into your package store as wealthy people who you could just pass a tax on, or they mostly working folks that are, buying their alcohol at the package store instead of going into the bar or restaurant?
Yeah, most of my clientele is working class people. Husband and wife both working, paying their bills, and a tax like this, not only does it hit them in the pocketbook, but they also it rattles them a little bit because we have to hear about it. It's almost as if we did it to them, and it's tough to explain to them that we did our best shot. We cut the deal we thought was the best deal in 2011 because we were told by doing it that way, every time the prices go up, the state gets a raise and we won't have to be back here. And I guess we did a pretty long time, but it's like, here we are again, after returning an additional $103 million to the state. It's like, I hate to ask you, but where is that money?
Good question. Thank you.
Thank you. Next, Delegate Johnson.
Thank you, Madam Chair, and thank you, panel. And whoever's best suited to answer this question, if you know. Can anyone tell us, since 2012, is there an increase or a decrease in alcohol sales facilities in Maryland?
Delegate, if I may, I can tell you the per capita consumption in gallonage, which is reported by the comptroller in 2012, was 21.034 gallons. In 2020, it was 17.561. So where you guys are realizing, the state, I'm sorry, is realizing their revenue is the prices are going up, and because it's a sales tax, you're getting more money, but our sales are flat. Look at the excise tax.
Can you tell us what it was in 2019?
The sales and use tax was $103,548,010.
I'm sorry, the gallons.
17.914.
Okay, thank you. Thank you, Madam Chair.
My pleasure. Any other questions for this panel? Seeing none, thank you very much for being with us today. We really appreciate your testimony. And this concludes the bill hearing on House Bill 463. Have a great evening.
Thank you.
Thank you for coming to be with us. Next, we have House Bill 22. Seeing none, thank you very much for being with us. Is Delegate Love here? Take your testimony. And this
I'm sorry, did you call on me, Madam Chair?
Yes, I did.
Oh, I'm sorry. I was just getting off of mute. My apologies.
It's okay. Well, good afternoon and welcome to the HGO Committee.
Thank you very much.
Testimony.
Yes, thank you. Good afternoon, or I should say evening, everyone. Thank you so much for having me. I'm Delegate Sarah Love, here to present HB 22, which would ensure that Maryland takes the next necessary actions to protect us from toxic PFAS chemicals. You may recall from your work last year that PFAS, per and polyfluoroalkyl substances, are highly fluorinated industrial chemicals. They create a barrier to stop grease and oil, so we're used in a number of different materials, from firefighting foam to food packaging. That barrier in your food container that keeps the grease from ending up in your lap, likely PFAS. Convenient, but dangerous. PFAS have been linked to serious illnesses, including testicular, kidney, liver, and pancreatic cancer, reproductive problems, low birth weights, as well as weakened immunity among children. In addition, these chemicals remain in our body and rarely break down in the environment, earning them the nickname forever chemicals. There are hundreds of instances of PFAS contamination nationwide. I'll just name a few here at home. Testing showed elevated levels of PFAS in oysters in St. Inigo's Creek. The Navy reported groundwater near Andrews Air Force Base containing high levels of PFAS. So states across the country are addressing this, as is the EPA. MDE is aware of this problem and has a roundtable looking into it. All of this brings me to HB 22. This bill takes its inspiration from legislation across the country and looks at three main areas: source reduction, disposal of the foam, and working with MDE on a PFAS action plan. So under source reduction, we're addressing three things. One, firefighting foam. This bill takes your work from last year where you banned the use of firefighting foam with intentionally added PFAS for testing and training and takes the next step to a full-on ban of this foam. Where this foam is required under federal law, HB 22 requires oversight. At least 5 states have banned the use of this foam, as has Australia. There are viable alternatives. The DoD is phasing it out, and our firefighters support it. The next piece is rugs and carpets. HB 22 will prohibit the sale or manufacturing of rugs or carpets that contain PFAS. Vermont is looking at this legislation, and retailers understand the problem and are taking action. So IKEA has already eliminated PFAS in their textiles. Home Depot and Lowe's have announced their commitment to end the sales of carpeting treated with PFAS. And the final bucket on source reduction is food packaging. It will again ban prohibit the sale or manufacturing of food packaging that contain intentionally added PFAS. So the use of PFAS in food packaging is widespread. The inside of cans for canned goods, the inside of microwave popcorn, and as I mentioned, fast food. 3 states have banned PFAS in food packaging: Giant, Whole Foods, Trader Joe's, McDonald's, Chipotle, Taco Bell. I could go on, but a number of these companies have made commitments to phase out PFAS in food packaging. So the second bucket is the disposal. This bill will also ensure the safe disposal of the existing foam to make sure it's not disposed of in a landfill or through incineration. New York has an incinerator that burns this foam, and it's from their language. They passed a law banning it last year. So it's from their language that we took the language in our bill. And the last piece includes uncodified language to require MDE to come up with a PFAS action plan. So in closing, I just want to mention, over the interim, I watched the movie Dark Waters with Mark Ruffalo. It's a really powerful and true movie about an attorney's fight on behalf of a community in West Virginia that was poisoned by the PFAS in Teflon. That case took nearly 2 decades of fighting DuPont. Just last week, DuPont, Corteva, and the Chemours Company announced a $4 billion fund to cover liabilities for their past use of PFAS. But even in light of that, this issue isn't over. One of the challenges is that last I heard, there were over 9,000 different variations of PFAS. So when one is challenged and found to be a health hazard, the chemicals companies shift to, just shift one component and move on because that one isn't regulated. So we need a broader approach, which is what HB 22 does. With that, I respectfully request a favorable report, and I'm happy to answer any questions. Thank you.
Thank you. Thank you for being with us. Next, we have Ms. Linda Bourbon.
Hey, I'm supposed to have some slides that go up here that I think are being shared with all the participants.
Okay.
I'm not sure.
You have 2 minutes to present your testimony. Thank you.
Thank you. Yes, thank you very much. So I'm going to talk about some of the health effects. You've heard from your legislator about all the problems, that there were 9,000 of these chemicals, and that I should tell you that we are all exposed. The CDC conducts a biomonitoring program around the United States every other year and has found that greater than 98% of Americans carry these compounds in their body. And they come to us from various places. Not only water, not only food packaging, but also just from the dust that's in our homes and so on. This is just kind of a schematic of all the different kinds of effects that PFAS can cause. Basically, if you think of a certain tissue or organ or stage of development, from the fetus up to older people, PFAS can cause effects. And these effects include what I have pictured here, but very briefly: testicular cancer, kidney cancer, ulcerative colitis, which is an autoimmune disease, high cholesterol, pregnancy-induced hypertension, thyroid disruption, hormonal changes, liver malfunction, obesity, immunotoxicity. And I should mention, recently there's been evidence that the severity of COVID infection may relate directly to the levels of some PFAS in your body. Lower birth weight and size for babies, delayed puberty, decreased fertility, early menopause, reductions in testosterone, prostate cancer, ovarian cancer, I could also say breast cancer, and bone density decrease, which means more likely to have breaks. Could I have the next slide, please? What I wanted to kind of tell you is where we are with some of the key research questions. One of the key issues is we're not measuring all the PFAS that are out there, no matter how. We're only measuring a small amount. We really need to ask the question, where do we really need it? And we need safe alternatives, not just unfortunate substitution. And we really need to approach studying PFAS as a class. This has been recommended by the National Academies of Sciences, and in fact is not new to how chemicals can be regulated. And we ask ourselves in closing, why do we make chemicals that will never go away? Didn't we learn anything with some of our old chemicals like PCBs, organochlorine pesticides, brominated flame retardants, and I could go on.
You have to wrap up, ma'am. Your time expired. Can you wrap up, please?
I did. Thank you.
Oh, wonderful. Excellent. Thank you so much. Next, we have Miss Emily Scarr.
Hi, members of the committee. For the record, my name is Emily Scarr. I'm the director of Maryland PIRG, the statewide consumer group, and we support HB 22 to protect our communities from PFAS exposure. As you've heard, we are just beginning to learn the extent of PFAS contamination in the state. But one thing I've learned over the last year of quarantine with my 2 toddlers is if your sink is overflowing with water, the first thing you do is turn off the tap. And it is definitely time for us to turn off the tap on new PFAS contamination. So as you can see from my written testimony, the PFAS Protection Act has a broad range of support from environmental groups, and in communities across the state, Marylanders are concerned about PFAS in their drinking water, in their seafood, and in consumer products. Just last week, you might have seen in the news that there is contamination in Hampstead and Westminster that the MD had reported growing concern in those communities. The proposed policy is based on existing policy throughout the country, as you've already heard, and aligns with corporate trends in addressing PFAS uses, catching Maryland up, and addressing this crisis. You can also see attached to my testimony a list of those companies that have already taken action that the delegate mentioned. So to be clear, this bill does not ban all PFAS uses. Instead, it restricts PFAS where they are both non-essential and easily replaceable with safer alternatives, and where multiple states and companies have already acted. As you heard from Dr. Birnbaum, it's really essential that we regulate PFAS as a class and move away from these non-essential uses. We likely have an uphill battle in front of us to deal with PFAS contamination in the state. I don't want to underplay that. We need to stop new contamination, which this bill can do. And in years to come, we likely do need to deal with the legal implications, how to hold polluting industry accountable, and how to get the funds to remediate in our state. Because of this unusual session, we didn't think we should do that yet, but this is a really important step we can take during this COVID session. So we strongly urge a favorable report.
Excellent timing. Thank you. You take the prize today. Next, we have Mr. Brent Walls.
Good evening, Madam Chair and members of the committee. My name is Brent Walsh, and I'm your Upper Potomac Riverkeeper with Potomac Riverkeeper Network. We are an environmental advocacy organization protecting the public's right to clean water. I have an environmental science background and have been working in environmental issues for 20 years. I'm also a Navy veteran who has worked with firefighting foam personally, AFFF, and I am concerned about my personal levels of PFAS. My 18-year-old daughter is a first responder firefighter that could also be exposed to AFFF during her career, which I'm concerned for. For 2 years, I've been also assessing the extent of PFAS pollution in the Upper Potomac. I've reviewed the conclusions of the CDC, the Agency for Toxic Substances and Disease Registry, from the PFAS exposure assessment conducted in Martinsburg, West Virginia last year. The agencies concluded that the elevated levels of PFAS in 300 residents tested were exposed to PFAS by ingestion of water and food products, as well as inhalation of dust particles from rugs, carpets, and upholstery that have that stain-resistant PFAS compounds. I have also collected water samples from streams and private wells in the Upper Potomac that have shown elevated levels of PFAS. I have tested the discharge from 2 Maryland wastewater treatment plants on the Antietam Creek in Washington County. Both wastewater plants showed high PFAS levels in their discharge, and the background levels of PFAS in the Antietam Creek were also elevated. These 2 wastewater plants do not have any industrial manufacturers of PFAS or PFAS-related products. PFAS from these systems are from residential and commercial sewers. The PFAS levels are coming from their waste, their washing machines, dishwashers, personal care products, and 40,000 plus residents. I have also uncovered data from USGS fisheries biologists that sampled over 30 smallmouth bass for PFAS in Antietam Creek and found that all 30 samples showed PFAS levels over 1,000 times higher than that of EPA's drinking water guidance. This bill is the first step that Maryland should take in the protection of Maryland citizens from this man-made chemical. I urge the committee for a favorable report. Thank you.
Great timing. You're on a roll here. You have to share the prize with Ms. Scar. The next one is witness is Mr. Jeffrey Buttle. Good afternoon.
Good evening, Madam Vice Chair. Thank you. Jeff Buttle on behalf of the Professional Firefighters of Maryland. We're here to support this piece of legislation. PFAS is something that causes long-term exposure. When the delegate bill sponsor introduced the bill, when she says forever chemicals, it's once they get into your system, they stay there for a really, really long time. And it's that exposure over a long period of time that ends up causing cancer, particularly in firefighters who have a much higher rate, as this House of Delegates knows, through some of the efforts you have done to protect firefighters and make sure that they're covered for cancers. What this bill would do is eliminate one of the sources of the toxic chemicals for the next generation of firefighters to hopefully make sure that they're not exposed to the chemicals that cause cancer in the first place. I do think that we're fully supportive of banning PFAS and phasing it out so that we no longer use it. I know there are some unique challenges up at BWI Airport. Some of those are highlighted in the fiscal and policy note, but we're happy to work with the bill sponsor to work through some of those. But we are fully supportive of the intent of the legislation and urge the committee to give it a favorable report. And Madam Vice Chair, I'll break the streak here and just end my time early and yield my time back to the committee.
Wow, I'm impressed. Thank you so much for being with us and thank you for your service. Next, we have Mr. Eric Galley.
Hello, Madam Chair, Madam Vice Chair, members of the committee. Feeling the time pressure, but I think I can do the 2 minutes. My name is Eric Galley. I'm here today representing the National Resources Defense Council. Normally, you would have former Delegate Tom Hooker in this spot, but he is working so hard running the Montgomery County Council, he couldn't be available today. So sorry, you're stuck with me. Yeah, I was looking through the bill file from the Senate hearing, and it's rare to see a bill with so much written testimony from such a broad group of organizations and causes. That's how environment, public health, NARAL's in there. That's how broadly pervasive and dangerous these chemicals are. And it brings me to the old ounce of prevention is worth a pound of cure argument. You all spend so many hours in here trying to deal with the ever increasing cost of healthcare, costs that make it hard for people to keep their private insurance, costs that make it hard for people to obtain their prescription drugs, costs that balloon the state budget because of Medicaid. And across the hall at E&T, they deal constantly with the cost of cleaning up our dirty environment. Reducing the amount of disease and bad health outcomes is the only viable long-term solution to these problems. Preventing disease and illness is what gets us off this treadmill. The less we dirty this planet, the less we spend cleaning it up. Other states are doing this in one form or another. Companies like McDonald's are voluntarily working on developing substitutions, so there will be enough market forces for the alternatives. Their costs will come down as they are mass produced, and the benefits to society in terms of public health, the environment, and even economics will be strong. So thank you so much for your time and attention today on this bill. We urge a favorable report, and we look forward to working with you to reduce bad health outcomes and reduce the cost of providing health care and cleaning up the environment. Thank you very much.
Thank you very much. I appreciate you. So are there any questions for this panel? I see Delegate Collison. Delegate Collison.
Can you hear me now?
Yes, we can.
Okay, great. Thank you, Madam Vice Chair.
This question is for Dr. Birnbaum. Is it true that you had a national role in environmental health science? And if so, do you have a sense of any work at the federal level on how to manage some of the chemical usages and disposal on this and the PFAS?
Yeah, thank you. That's a great question. I was the director of the National Institute of Environmental Health Sciences, which is part of the National Institutes of Health. I was also the director of the National Toxicology Program, which involves CDC, FDA, and NIH. I retired about a year ago, and was granted scientist emeritus status so I can continue some of my own research. And I'm also a scholar in residence at Duke. What we know about the need to manage these things, I do know that EPA in its Office of Research and Development is studying different ways to try to break down this material. There have been some approaches that get it partially broken down, not fully. There are attempts to be able to incinerate. So far, those have not led to complete breakdown, and you end up generating products which are even more toxic. But I do know that they're working on that. From food and food packaging, for example, they're actually being banned in several of our other states have actually banned that to go into effect by, well, some have already gone into effect and some by 2022 or 2023. Denmark has totally banned the use of that. And with the authorization of the National Defense Authorization Act for 2020, the Defense Department can no longer purchase any food which is sold or stored in PFAS containing materials. FDA has moved to begin to prevent the use of some of these chemicals, but there's quite a long way to go. So that's just a few examples.
Great. Thank you very much. And thank you, Madam Vice Chair.
My pleasure. Next, we have Delegate Johnson.
Thank you, Madam Chair, and thank you, panel. Whoever's best suited to answer the question. Are there any essential uses that are considered critical uses that there are no substitutes on the horizon yet for this chemical?
I'm going to take a quick stab at that, but we may want to turn it to someone else. You can break essential uses into three categories. There are those for which there are existing, there are things that aren't essential. Maybe we really don't have to have our tablecloths or our carpets totally stain-proof. There are issues where it's something that's needed, but there are safe alternatives, not regrettable alternatives. And then there are some things which are, so far, there are no substitutes. And some of that includes certain medical use and certain medical equipment and practices.
Thank you. Thank you, Madam Chair.
My pleasure, Delegate. I don't see any other questions for these panelists. Thank you so much for your testimony. Next, we have a panel on favorable with amendment, Mr. Michael Sanderson. Good afternoon, sir, and thank you for your patience. Will you be so kind and get started?
Thank you very much, Madam Vice Chair and committee members. I'm Michael Sanderson with the Maryland Association of Counties. We've submitted written testimony, support with amendments on the bill. Our interest here in local government is on the use as a firefighting foam. And essentially all we're asking for as you consider this policy, we don't quarrel with the centerpiece of the policy. We think our fire companies should get some sort of a soft landing here. So if the bill essentially says you can't sell and you can't use after date certain, we're looking at just the back half. We're fine with a date certain on no longer purchasing this chemical, and particularly the advancement of a viable replacement makes that position, I think, reasonable for our local fire companies. Either give us the time to use the stuff that's already been purchased in good faith and let us spend down that supply, or alternatively, if it's in your judgment too urgent to do so, let's find a way to give our fire companies some sort of a soft landing, some sort of a grant or some assistance to help them convert to the non-PFAS foam, the greener foam alternatives. So either of those directions, I think could make this bill more palatable for local fire companies who have basically done what they needed to do within the law and in good faith and are going to be caught in the switches here. So a soft landing of some sort is our amendment. Thank you very much.
Are there any questions?
Are there any questions of this witness? 1 second.
I don't see any questions for this witness. Next, we have an unfavorable panel, Michael Rashford.
Madam Chairwoman and members of the committee, thanks for the opportunity to speak with you this afternoon. I'm Michael Ratchford, an associate with I'm Michael Ratchford. I'm an associate with W.L. Gore and Associates, privately held company and a Maryland manufacturer since 1973. Gore employs approximately 2,900 associates in Cecil County. We make a number of technologically advanced products of high societal value. In fact, we're the largest private sector employer in the county. I'm here this afternoon to speak in opposition to House Bill 22. While Gore does not make firefighting foam, rugs, and carpeting or food packaging, we do use fluoropolymers, which are included in the 4,000 to 7,000 substances defined as PFAS in this legislation. We believe the definition of PFAS is overly broad and could lead to the unintended restriction of fluoropolymers. Gore uses fluoropolymers to make products of high societal value, including implantable medical devices, Gore-Tex membrane, venting and vent filtration used in emission controls, and products used in the pharmaceutical industry to make COVID-19 vaccines. 3 concerns with the legislation. First, the definition of PFAS is overly broad and includes fluoropolymers, which are highly stable, too large to be bioavailable, and do not have the potential to become widespread in the environment. Secondly, the timeline for transitioning retail products is unrealistic. In the absence of a regulatory assessment on performance of alternatives, there is no means to demonstrate that replacements will be an improvement. Third, the proposed definition of food packaging is very broad and could be interpreted to cover a wide variety of products. Due to the complexity of this topic, we believe the better course of action is to establish a regulatory program rather than effect a legislative ban. For these reasons, we ask for an unfavorable report on this legislation.
Great timing. Next, we have Mr. Mitch Hubbard. Mr. Hubbard, good afternoon. Mr. Mitch Hubbard?
I'm sorry, I'm here. Honorable Chair Pendergrass and members of the committee, my name is Mitch Hubert. Thank you for the opportunity to address your committee today. I hold degrees in both biology and chemistry and have been working in the firefighting foam industry for more than 40 years as a formulation chemist and as a firefighter. I'm here today representing the Firefighting Foam Coalition to urge you to reconsider House Bill 22. Our coalition is made up of foam manufacturers throughout the world who fully support the efforts to reduce the use of PFAS foams and are working feverishly to improve fluorinated alternatives. Unfortunately, there are still fire scenarios and industry segments where the current technology utilized in fluorine-free foams falls short of providing the type of performance that can assure large catastrophic fires can be successfully fought and extinguished and provide a measure of safety for the firefighters and other first responders. As I said, the FFFC fully supports transition away from the use of PFAS-containing firefighting foams, but we believe reasonable transition period of 5 years, consistent with those in the European Union and New Zealand, is a more realistic and achievable goal. The vast majority of PFAS contamination comes from past uses, and your legislation that you passed last year takes care of most of those potential releases to the environment. You are already where you need to be in the short run. We would like to ask for some continued uses in areas such as refineries, chemical plants, bulk fuel storage tanks and marketing terminals, and also in fixed foam systems, particularly in sprinkler systems, where we don't have good drop-in replacements. There are no such thing as drop-in replacements. Finally, the proposed bill has an impact from a retroactive recall that we would not be able to potentially meet. With that, I ask you to just reconsider some of the issues in your House Bill 22. Thank you.
Thank you, Mr. Hubert. Next, we have Mr. Sean Swearingen.
Thank you, Madam Vice Chair, members of the committee. I appreciate the opportunity to testify and speak to House Bill 22. My name is Sean Swearingen. I'm the director for the Alliance for Telemer Chemistry Stewardship, known as ATCS. It is a global organization that advocates on behalf of C6 fluorotelmer-based products. I'd like to underline today how broad HB 22 is and how far-reaching the unintended consequences that HB 22 creates as written. While the intent of legislation is to regulate PFAS, what's clearly not understood is how vast and wide-ranging these chemicals are. As an example, the broad definition of PFAS contained in HB 22 have widespread unintended consequences, and as written, the definition includes hundreds, if not thousands, of different chemistries as previously mentioned. The definition should focus on the specific chemistries of concern because of this broad definition, it creates a patchwork of regulations that negatively affect and impact the people of Maryland and the businesses that rely on these products. A critical component of HB 22 is its language also seeks to undertake further regulation of food packaging materials, when the industry is already phasing out use of PFAS in food packaging by the end of 2023. Because of the recent increased attention to the family of PFAS and the use of certain PFAS chemistries in food packaging, the FDA has already undertaken a reassessment of these applications. In connection with this reassessment, manufacturers of the majority of PFAS products in fiber-based food packaging agreed to voluntarily phase out, leading to the discontinuation of sales of these products for use in food packaging as of January 1, 2024. Reflected in its announcement of the agreement, FDA concluded that this phase-out period is needed to avoid unnecessary food supply chain and market disruptions. Recently, as previously stated, McDonald's has even further announced that it will cease food sales with packaging containing PFAS at the end of 2025. In conclusion, we recommend a clear definition of PFAS while underlining the different class of chemistries, restoring the bipartisan fluorinated firefighting foam regulations, and aligning food packaging sunset to align with FDA in December 31st, 2023. Thank you.
Thank you for your testimony today. We have Mr. Robert Simon. Good afternoon, Mr. Robert Simon. One more time, Mr. Robert Simon, are you here?
He's in the room, but I don't know what's going on.
Mr. Simon, will you be so kind and unmute yourself so you can provide us with your testimony? Mr. Simon? All right. So are there any questions for this panel? Seeing none, this will conclude the bill hearing.
Madam
Seeing
Chair.
none, I'm sorry, my internet is going a little crazy this afternoon, but this will conclude the bill hearing on House Bill 22.
I did have my hand up.
Next, we're going to move on to House Bill 108.
Sorry,
House Bill
Vice-
108 is actually Delegate Charkoudian. Good afternoon, Delegate.
Vice Chair, I think we do have a question from Delegate Riley.
Sorry, you must not have seen my hand. We still good or no?
I think her internet's gone down.
Vice Chair, you're muted.
I'm sorry, I did not see your hand. I apologize.
Oh, okay, sorry.
Okay, are they still here or did they leave?
Yes, my question was for Mr. Michael Radcliffe.
Yes.
Radcliffe,
Delegate
sorry.
Riley.
Hi, how are you?
Go ahead and ask your question, Delegate.
Okay, all right. Thank you for your testimony. It actually brought a light, I think, to something that the bill doesn't actually address.
And that is all the medical supplies, which I think is really important to this committee. So are you suggesting that if we don't put an amendment on this particular bill to take those items out, that, this could be really crucial to our medical facilities and our hospitals and our doctor's offices and even the vaccine you mentioned?
So Delegate Riley, I think even Dr. Birnbaum said that, medical products could be considered essential products. I think in terms of the legislation, we would suggest that you could exempt fluoropolymers, which are different from some of the other in the PFAS category.
Okay.
And or secondly, we would suggest more of a science-based process to go ahead and consider all the chemistry within PFAS. You could break them into various classes of PFAS based on their characteristics. So we're just suggesting a different sort of approach. But yes, you could see medical products could be at jeopardy here if you.
Okay. Oh, sorry. Thank you very much. I appreciate that. And you would be willing to work with the, either the sponsor of the bill or our committee to make sure that we don't jeopardize our health?
I've already had, and I appreciate the time to speak with Delegate Love about that.
Great, excellent.
Commenting on the bill is written, so thank you.
Thank you.
Thank you. My pleasure. We have Delegate Chisholm has a question. Delegate?
Thank you, Madam Chair. And I wasn't going to ask until Terry or Delegate Riley got on, because I remember going through this last year with the polymers as well. And it seems to me this bill is so wide that even, for instance, solar panels have polymers in them. Are we going to ban the solar panels that we're using on top of roofs as well? It just seems like we use polymers. And I remember this last year, I remember talking to Nick Manis. We use polymers in just about everything. I understand that there's a safety component involved in this, but I don't think everybody grasps how many different products we actually use these polymers in. And I understand trying to keep them out of the, I guess, the concerns of food products and that sort. But we get into electronics, we're talking about cell phones as well, and the circuit boards that they use. And if I'm reading the bill correctly, are we going to eliminate anybody from being able to produce a cell phone or a circuit board? I mean, we do a lot of that in the state of Maryland, and I guess I'm just looking for clarification.
What is the question?
Are we using this broad sweeping term of PFAS to include all of these polymer products?
So, sir, can you answer that question?
So I would say that the concern is the unintended consequences, Delegate, that you've raised here. And I would say that not all PFAS are the same. I think that there is a recognition that, there's different types of PFAS and that you've got 9,000 types of PFAS. You can only imagine the number of products that it's in potentially. Now, there are a group of these PFAS that are problematic and they should be regulated strictly on it. But this, I think, points to the need for a scientific review of these chemistries before you go making broad pronouncements. Your point is well taken.
Thank you, sir.
Thank you. Any other questions? I don't see any other. However, I've been told that Mr. Robert Simon is here, and because he waited, it's already 6:30. I'm going to allow it. Mr. Robert Simon, can you please speak up, unmute yourself?
All right. Thank you, Madam Chair and members of the committee. And I apologize. I was disconnected and I reconnected. In the interest of time, I don't want to waste the committee's time. I'll note two things. One, on a completely unrelated note, and I'm not scheduled to testify on this, I did just want to recognize the leadership of Delegate Carlson on HB 484 as someone who's lost a parent to complications with dialysis. I truly support that effort and the committee's effort to look at ways to continue to use dialysis safely. On HB 22, I'm speaking on behalf of the American Chemistry Council, testifying in opposition to the bill, but there, as you've heard from some of this panel, I think there's more common ground here than maybe some would believe. So I think focusing on the definition focusing on those things that really could get into the environment, ensuring that Maryland government, Maryland citizens, and Maryland businesses aren't impacted by the unintended consequences of the current version of HB 22. We support a lot of the elements. We think with some targeted enhancements, there could be even broader support for this. And we look forward to working with Delegate Love and the committee to consider some of those amendments, and appreciate your time. And again, apologies for joining late.
It's our pleasure. Are there any questions of this particular witness? Seeing none, this does conclude the bill hearing on House Bill 22, and we're going to move on to House Bill 108, Delegate Charkoudian, Behavioral Health Crisis Response Services. Delegate. Good afternoon, Delegate.
Oh, I'm sorry. Was I called on? I didn't hear that part. You ready for me?
Yes. Could you?
Okay. Thank you.
Good afternoon. Yes. Can you present your bill to us, please?
Yes. Thank you. Thank you. For the record, I'm Delegate Lord Charkoudian. I'm here speaking on behalf of House Bill 108, asking for a favorable report. And so I want to begin actually by thanking all of you. Many of you have over the years worked very hard to improve the mental health system in the state. And I want to thank you for that on behalf of my constituents, on behalf of Marylanders, and just for a moment personally, as someone who's a family member of someone with bipolar disorder who has been mixed up in the criminal justice system as a result of his mental illness. So I thank you for all of that. And tonight I ask you to work with me to move this forward, to move the mental health system forward, and to improve our ability to respond to mental health crises in ways that help people get treatment for their disease as opposed to criminalizing them. And so the bill that you have in front of you builds on the mobile crisis unit model. I think this year, many of you have been involved in really looking at, as we've had a reckoning with this question about how police are used in our communities, and an understanding that when police respond to mental health crises, often things don't go well. People end up dead, people end up criminalized. In my own community this year, Finhan Berhe was killed by a police officer. He was suffering from a mental health crisis that was made worse by COVID-19. And so my community really has spent the last 6 months looking at this and looking at what are the other solutions. So what we have in Maryland is a good model for mobile crisis units. This bill strengthens that in a number of ways. First, it increases the funding over the next several years, so in 2023, 24, and 25, and it makes sure that of the crisis response funding, that a portion of it goes to mobile crisis units to make sure that we always have mobile crisis units receiving the grants under this fantastic grant program that we have in the state. The second really important thing that it does is it supports connecting 911 to mobile crisis units. One of the things that we need to do is to educate our community members to not always be calling 911 and to call the various other resources that are needed. But in the meantime, people do continue to call 911 when they are experiencing crisis. And in the same way that 911 has the ability to conduct some triage and determine whether we're sending police, law enforcement, a first responder, fire and rescue, EMT, we want to make sure that within that mix, there's also the ability to send a mobile crisis unit when mental health professionals are what is needed most in that response. Second, it requires that we are designing our mobile crisis units in a way that limits interaction between somebody struggling from a mental health crisis and law enforcement. That doesn't mean that it's not ever possible for law enforcement to be part of the response, and that can be determined in the moment, depending on depending on the situation and professionals' opinions about it. But that the overall design is one that is designed to make sure that it is mental health professionals responding to crises, to mental health crises, and limiting the interaction of law enforcement, because we know that often people who are suffering from mental health crises may be triggered and further escalated by the presence of law enforcement. A third area is requiring that the mobile crisis units ensure cultural competency and language access. As I have been working with my community, especially in response to this death in our community, I've learned more and more about crisis response and even mental health services that haven't sufficiently taken into account the cultural needs or language needs of the people they're serving. And finally, this bill requires that the mobile crisis units develop community involvement plans in their design, feedback, and evaluation. And I think that we know that all of our programs are stronger when the community is engaged in building them, and it also builds more community trust when the community is involved in building them. And so it will sort of reinforce the community trust piece of it. I've also shared with you amendments. The amendment that I have, the bill as it is not amended at this point, although of course I'm always open to amendments and suggestions from the committee and from others who work in this area. I did write a preamble to go with the bill that really puts it in context, puts the bill in context for a lot of the issues that that we have been talking about, issues about cultural competency, issues about the realities and the challenges of asking law enforcement, who we ask to do so much, to also be responding to mental health crises, and problems with that approach, and why mental health response is a stronger approach. So you have that. You can choose to add that if you want to. I'm happy to talk about that more if there's questions. I think it does strengthen the bill. I don't think it's crucial for the bill to have its intended impact. And I thank you for your time.
Thank you so much for your testimony this afternoon and for your patience today. Next, we have Ms. Adrienne Bridenstine.
Members of the committee, I'm Adrienne Bridenstine. I'm with Behavioral Health System Baltimore. Thank you for hearing my testimony this evening. You have a copy of our written testimony in your packet already, so I'm just going to make a couple of points, but BHSB is here in strong support of HB 101. Mostly because this bill does a lot to support a number of initiatives that we have going on in Baltimore City. One being the GBRICS initiative, which we briefed this committee on a couple weeks ago. It's intended to expand and strengthen behavioral health crisis services, not only in Baltimore City, but also in Baltimore County, Carroll County, and Howard County. One of the ways we plan to do this is through expanded mobile crisis. The goals are similar to what's in HB 801, which is to reduce and minimize police involvement. The second is through advancing our efforts to really address behavioral health findings in the Baltimore City consent decree. In 2019, Baltimore City did an analysis of our public behavioral health system. In that analysis, we found that the city 911 center gets over 13,000 behavioral health calls annually. We know that with expanded mobile crisis services that we can better respond to these calls that are coming through 911 if they're diverted to our system. This bill would help to support that with that mobile crisis team expansion and the additional funding. And finally, we are just really excited about the language that's also included that highlights that we do want to minimize police law enforcement involvement. That will help us with future years to build out the system that we really need to better address behavioral health needs. Thank you for hearing my testimony this evening.
Thank you so much. Excellent timing. Next, we have Mr. Brandon Rubin. Good afternoon, Mr. Rubin. Will you get started, please?
Good evening, Madam Vice Chair and committee members. My name is Brandon Rubin. As a citizen of Prince George's County and an attorney at the Office of the Public Defender, I speak to offer my strongest support to House Bill 108. As I note in my written testimony, few interventions promise to promote the efficacy, efficiency, and moral authority of Maryland's public safety system more than House Bill 108. Popular perception imagines the criminal legal system to deal mostly with rapes, murders, and other horrible acts, but that's not true. In Maryland and nationally, at least 80% of calls for police service, arrests, and prosecutions are for petty conduct, often related to mental illness and poverty, that we currently criminalize as misdemeanors. For example, just last month, I went to trial defending a disabled 60-year-old man accused of throwing a rock at a minivan in search of somewhere to sleep. Legislation like House Bill 108 provides a path to move beyond our current inhumane, inefficient, and ineffective punitive and carceral response to imperfect human behavior. Indeed, funding mobile crisis units to respond to conduct that we currently criminalize as misdemeanors will, in all likelihood, accomplish no less than 1, reducing officer-involved deaths and injuries, 2, connecting people with practitioners specifically trained to aid in problems they may be experiencing, and 3, reducing unnecessary and highly costly arrests, prosecutions, and incarcerations. Certainly, back-end public safety solutions, like making misconduct records more transparent in police departments, are critical in ensuring that bad acting officers are held accountable. But front-end public safety solutions, like House Bill 108, are the real drivers toward ensuring that unnecessary police use of force and killings and unnecessary arrests, prosecutions, and incarcerations do not occur in the first place. Thank you.
Thank you for your testimony and for the work you do. Next, we have Ms. Cyphers. Good afternoon.
Good evening, Madam Vice Chair and committee members. Maura Cyphers with Compass Government Relations on behalf of the National Alliance on Mental Illness Maryland. NAMI Maryland is strongly supportive of this legislation. Thank you to Delegate Charkoudian for introducing this bill. And I also want to thank this body for passing the original crisis grant funding program a few years ago. We absolutely need the additional funding this bill provides, but even more so, NAMI supports the changes the bill requires for mobile crisis units. Why are the proposed changes necessary? I'm going to focus on 3 quick priorities for NAMI. I know it's getting late, but 1, minimizing the role of law enforcement in mobile crisis. When a mental health crisis happens, it should get a mental health response. NAMI believes that responses to crisis situations should be met by well-trained mobile crisis teams that provide the de-escalation, help, and support people need. If mobile crisis isn't available, crisis calls may roll over to local law enforcement. And although many are trained to recognize crisis and de-escalate a situation, clinicians are best suited to this role. In the past week, a 9-year-old girl in mental health crisis was handcuffed and pepper sprayed in the face while being held in the back of a police cruiser. She was crying for her dad and saying how much her eyes hurt. This was an incident from Rochester, New York, but it's only one tragic illustration of how children and everyone else in a mental health crisis can be traumatized by an ineffective law enforcement response. The second reason why this bill is super important is cultural competence. So patients have a broad range of health perspectives. Cultural competency is the critical understanding and ability to communicate with the population you're serving. It reduces barriers to quality care, especially when there may be differences in linguistic and cultural norms. I will stop there, but we're super grateful to Delegate Charkoudian for introducing the bill. Got a million more reasons to support it, and we ask for your favorable report.
Thank you so much for your testimony. We appreciate it. Next, we have Mr. Dan Martin. Mr. Martin, good evening.
Good evening, Madam Vice Chair, members of the committee. Dan Martin with the Mental Health Association of Maryland here in strong support of House Bill 108. And I want to thank Delegate Charkoudian for introducing the bill. This has also been identified as a priority for the Maryland Behavioral Health Coalition this year. And so, as you've heard, HB 108 extends funding for the Behavioral Health Crisis Response Grant Program, which was enacted by legislation passed nearly unanimously in 2018 with strong leadership and support from this committee. And Delegate Rosenberg was the sponsor back then. Delegate Kipke, you and Delegate Brownwell were very much involved in the development of this legislation and this program. And so again, thank you for your past support and hope you'll support it again this year. The program awards grants to local behavioral health authorities to develop and expand their programs consistent with local needs. And if you'll remember back in 2018, that was a key part of this program. We want to make sure that to allow flexibility across jurisdictions. And when we introduced it back then, the funding was continuous, went on continuously, but it was decided to kind of just fund the program for a couple of years, and then come back and take a look at how it's going. And I'm here to say that it has become a really critical component of Maryland's behavioral health crisis response system. Just some of the programs that it's currently supporting, this grant program, it's responsible for expanding mobile crisis services in Baltimore City from 17 hours a day to 24 hours a day. It's increased mobile crisis to 16 hours a day in Carroll County. It's expanded walk-in crisis services in Frederick County from 48 hours a week to 92 hours a week. It's expanded mobile crisis and youth crisis in Harford County and walk-in crisis services in Harford County. On the shore, it's allowed the Eastern Shore mobile crisis teams to provide child and adolescent specific crisis intervention services in Caroline, Dorchester, Somerset, Talbot, and Wycomico counties where none of those services existed before. And so it's also supporting services in Calvert County, Howard, Prince George's, and Washington. And so, these services are important now more than ever, as you all understand, and I urge a favorable report on House Bill 108.
Thank you, and thank you for your advocacy. Next, we have Mr. Michael Sanderson. Good evening, Mr. Sanderson.
Good evening, Madam Vice Chair and committee members. I'm Michael Sanderson with the Maryland Association of Counties. We've submitted written testimony, and I would attach myself to the excellent presentation you heard from the sponsor and many of the advocates. I'll add 2 quick points from the county government perspective. Number one thing that we like about this bill is that it correctly reflects that we deliver this kind of service at the county level in multiple ways. Sometimes it's within the county government. Sometimes it's through a nonprofit or a partner non-governmental organization. This bill accommodates all those different flavors, and that's a good idea. Second, a little more technical, but one of the elements in the bill is incorporating in times of crisis, sort of the dispatch of the right resource. This notion goes, I think, hand in glove with the work of our Next Generation 911 Commission that's been working for a number of years. Hats off to Delegate Krebs and her leadership on this issue. I think the idea of let's get the right help to somebody who's dialing 911 or has had someone dialed on their behalf, let's get the right kind of help in those times of crisis is a good element in this bill. And I think it works well also to the benefit of our emergency dispatchers to keep these situations out of the police queue. So for a variety of reasons you already heard and a few other specific to county governments, we encourage a favorable on this bill.
Thank you so much for your work. Are there any questions of this panel? I see Delegate Kipke.
Thank you, Madam Chairman. Just
my pleasure.
If any of the mobile crisis units or any of the professionals that run them were consulted in developing the legislation.
Hi, Delegate Kipke. I'm happy to answer. NAMI did a survey of mobile crisis units in the states and their contacts to see kind of what support was needed. I'm happy to share those results with you. By and large, the folks we talked to were supportive of the effort.
Okay. I guess if you could share that, I would be curious to know. I mean, one thing I've noticed in Anne Arundel that seems to be really valuable is we have people who are true professionals at this, but then they also train police officers so that they're supporting each other. And I just, it jumped out to me. I know the intent is right, but to limit law enforcement's exposure to someone in crisis, obviously you don't want to make it any worse, but it seems like what's going on in Anne Arundel is working. So I'm sort of curious, did Anne Arundel County give any feedback on this proposal?
I'll double check. I know NAMI consulted with, Pete Barron reached out and Stuart Pittman have been in touch with them on some of their training modules, and they do a really good job. Overall, I think when folks are in crisis, there is maybe sometimes a safety element, but it's really better for a clinician to make that first contact rather than law enforcement. So I'm happy to go back to our survey, and then we can talk with you in Anne Arundel County about what's going on and what's necessary.
Thank you.
Thank you, Delegate. Any other questions for this panel? Seeing none, that concludes the testimony on House Bill 108. Now we have our last bill of the day, and thank you so much to the witnesses, and thank you for your patience. House Bill 29, Delegate Ivey, Health Standards for Involuntary Admissions and Petitions for Emergency Evaluations, Substance Use Disorder. Good afternoon, Delegate Ivy, and thank you for your patience.
Oh, thank you so much, Madam Chair, and to the entire committee for all of your work here. Last hearing and a long day of hearings.
Thank you for your patience. House Bill 29, Delegate Ivy. Mr. Deschamps, thank you so much.
Okay. Yeah, thank you so much again. Colleagues, for the record, Delegate Julian Ivy here presenting House Bill 29. Under state law, a petition to allow emergency evaluation or involuntary admission for an individual with a substance use disorder is prohibited unless they also have a mental disorder and meet other specified requirements. This legislation, as amended, would require the Maryland Department of Health to study and make recommendations regarding the circumstances under which a certain petition should be allowed to be made for an individual who has a substance use disorder. Secondly, this bill would ask the Department of Health to evaluate the effects of implementing any changes recommended on applicable state agencies, including on each agency's administrative and legal processes. The findings of the commission should be reported to the members of the House Health and Government Operations Committee, this one, and also your sibling committee in the Senate, no later than January 1st in 2022. Over the last 10 months, Marylanders, they've just been suffering the negative effects of increased social isolation, economic uncertainty, and immeasurable grief and loss as a direct result of the COVID-19 pandemic. Longstanding concerns about Maryland's substance use disorder crisis has become even more acute during the pandemic. Individuals suffering from substance use disorders find themselves isolated from their loved ones and are disconnected from essential rehabilitation services. People now more than ever need help, even if they're not able to recognize it themselves. The District of Columbia and 37 states have involuntary commitment laws so that individuals can admit people on their behalf to treatment facilities. Maryland should be one of those states. Maryland's drug overdose death rate is one of the worst in the country, and this is a growing problem for Prince George's County, where in the first 6 months of 2020, we had the largest increase in opioid-related fatalities. Families or concerned members should have the right to petition to involuntarily submit a loved one for emergency evaluation, as it could be life-saving. I ask for a favorable report on House Bill 29, as amended.
Excellent timing. Thank you so much. Next, we have Elena Suarez. Ms. Suarez, are you here? Good evening, Ms. Elena Suarez. Go on to the next witness. Ms. Jimena Deschamps. I see you, Ms. Jimena Deschamps. You have to unmute yourself, please, and provide the
Hello.
testimony.
Madam Chair, thank you for inviting me. We have 4 mothers that are testifying, and we had an order. I would ask humbly that you ask Lisa Lowe first, as we were kind of passing the baton to each other and had coordinated our testimony. So Lisa Lowe, and then Elena, and then myself were going to testify so that it makes more sense, if that's possible.
Ms. Lowe, will you please get started? Ms. Lowe?
Am I unmuted?
Yes, you are. We can hear you clearly. Good evening.
Hello, Ms. Pendergrass. Pena Melnick, sorry about that. As you know, I'm Lisa Lowe with Addiction, Maryland. I'm here today with 3 moms, 2 of whom have lost their children to fentanyl overdose, and 2 of us have children struggling. We support Delegate Ivy's initial involuntary commitment for substance use disorder and vehemently oppose any efforts to turn this bill into a study. The opponents here will argue that the research shows that involuntary treatment for people with substance use disorder is not effective. And while these studies do exist, there is other equally reliable research that shows that it is effective. And we'd just like the opportunity to sit down with the opponents, compare the little bit of research that exists in enough time to save the 2,000 plus individuals that will likely die of overdose this year. They will also argue that Maryland does not have a comprehensive continuum of care adequate to meet the needs of those who actually want treatment, much less for those who don't. And I'd like to point out that all of those who do want treatment may not want treatment when they wake up tomorrow as a result of the confused thoughts that accompany their diagnosis. The opponents will also argue that this bill will exacerbate the overcrowding of ERs and psych wards and hospitals. However, as we have pointed out in past years and past bills, if the hospital spent 1% of the salaries of their executives that earn more than $1 million a year, they could easily expand their services to provide this level of care. The Maryland Hospital Association was mandated by this very committee to report on the extent to which this would be possible, but the outcome of that report has yet to materialize. In conclusion, I would like to say that, opponents will complain that if HB 29 is passed, the department will need to revise regulations to address SUD, consider new construction to meet increased demand for beds, and hire additional staff to accommodate a potential increase in patients. But with the ever increasing annual death rate from overdoses, shouldn't the department have considered those steps several years ago? And if they haven't done so already, isn't it high time that they did? And I'd like to pass the baton on to Jimena.
You have to wrap up, Ms. Lowe.
I'm finished.
Okay. Can you hear me?
Yes.
All right. Thank you. Thank you. Next, Ms. Elena Suarez.
Miss Jimena Ryan, please, as
Okay.
we in a certain order. Thank you.
That's fine. Can you go, Ms. Jimena, please?
Yes. Can you hear me?
Yes, we can hear you clearly.
Thank you very much. Thank you, Madam Chair, Madam Vice Chair, Delegate Ivy, and members of the committee. I will continue on the track of the testimony that we've prepared together. The opponents will say that ER departments are not equipped to handle opioid patients who undergo withdrawal by starting them on opioid maintenance medication or detox. The fact is that we do not have a Suboxone doctor in every hospital in the state when we are ranked number 5 in the nation for overdose deaths. This explains why we are ranked number 5 in the nation for overdose deaths. This, of course, could be added as an amendment to this bill. The opposition will tell you that general hospitals with psychiatric units that accept involuntary patients are not substance abuse rehabilitation facilities. And just like suicide-prone patients who may not choose to enter the next level of treatment, under this original bill, overdose patients would have the same option. This initial bill proposes the same observation and evaluation for someone who was or who is only minutes or seconds or a single breath away from death, and it is likely to be again without intervention. The opposition will say that to commit someone primarily due to substance use disorder is an improper use of scarce psychiatric inpatient beds. Perhaps they have not yet received the 10-year-old news that this is a mental health disorder. There is a 70% correlation between bipolar and substance use disorder, but most importantly, that this particular mental health disorder claims more lives each year and all other mental health disorders combined. Elena?
Thank you for this opportunity. The opposition will also try to get you to buy the notion that no evidence of efficacy exists in the practice of involuntary committing those struggling with SUD. While some evidence of harm does exist, this is simply not true. While it is just in the medical community's most profitable interest to have you believe this, while supplying a scientific article or two, both of which are heavily biased, rather than a systematic review of all existing research, which could be completed by a layperson in as little as a week's time. While the opposition will acknowledge that commitment may achieve the immediate goal of preventing an overdose or related danger, they will try to convince you that the experience of being involuntarily committed is too stigmatizing and punitive, that it leads to heightened family conflict and social isolation, and it erodes patient self-determination. But both the family members and the patients themselves will tell you that the experience of being so controlled by a substance that you're willing to engage in the most unconscionable acts creates a trauma from which you will never heal, family conflict and isolation so pervasive that you see no way out, and such eroded self-determination that according to some research, nearly 50% of those experiencing chronic addiction will try at some point to commit suicide by overdose, thus exhibiting the only self-determination that they see as being within control at the time. In conclusion, on the contrary, family members save their loved ones from the stigmatizing, punitive, conflict, socially isolating, self-undermining behaviors inherent in deadly chronic addiction by using the involuntary commitment tool. And based on literally hundreds, perhaps thousands of firsthand stories, their loved ones are thankful and grateful that their family member interceded in their daily crisis, as was the case with my daughter. Every time she got sober, she was profusely thankful, which they felt powerless to overcome without intercession. Thank you for your time.
Thank you, and we're very sorry for your loss, okay? We really
Thank you.
are.
Thank you.
Next we have actually Yvette McGuire is the last witness for this panel here. Good afternoon, ma'am.
Hello. Hello.
Can
Hi
you
there.
get started, please?
Yes, can you hear me?
Yes.
We can hear you clearly.
Okay, thank you. My name is Yvette McGuire. I support involuntary commitment. Opponents will tell you that involuntary admissions are designed to avert an immediate crisis, and that substance use disorder does not present an immediate crisis, but waking up in a hospital bed after a near-death experience is an immediate crisis. They say that a 6 to 7 day stay where patients are stabilized on Suboxone or methadone does not effectively impact long-term recovery. However, many patients whose daily cycle of doing absolutely nothing except seeking their next drug dose in a desperate attempt to avoid dope sickness begin their long-term recovery after a 6 to 7 day period of stabilization. In fact, it would be safe to say that every single person who maintained long-term recovery began their recovery with a 6 or 7 day of medically monitored stabilization. Opponents will tell you that this bill may delay access to care for those with more acute mental illnesses that pose a danger to themselves or others, and if codified, may inadvertently extend waiting times in an emergency department rooms, boarding and holding beds for serious mental illness patients, as if the 2,000 plus patients who died of overdose last year did not fit the description of having an acute and serious mental illness such that it posed danger to themselves. Opponents will tell you that treatment or substance use disorder differ from mental health disorders in that treatment focuses on patients' engagement for
You have to try to wrap up.
We're addressing the underlying substance use disorder as opposed to certain for treatment of acute intoxication or overdose. But when you first thought after waking up from an overdose is, oh no, I'm going to be violently sick if I don't get another dose of opiates, then you do not have a sliver of a chance to even consider patient engagement. Once the individual has been stabilized on opioid medication, they may then and only then be emotionally and mentally and physically capable of considering focusing on a patient.
Ms. Mawire, you have to wrap up, please.
Thank you.
Thank you so much. Are there any questions for these witnesses? 1 second. I don't see any questions for these witnesses. I want to thank you for your patience. I know you waited. We're so sorry for your loss, and we really do appreciate it, and we're really listening, okay? Next, we have Ms. Nancy Rosen Cohen.
Yes, good evening, Madam Vice Chair. I thank
Good
all of
evening.
you and the committee members. The people that just testified actually provided my testimony. I'm a parent a step parent that was involved with a situation with someone with a substance use disorder. And I want to say, I understand the frustration and the desperation of families trying to get their loved ones into care. And they also mentioned the research. I've attached research about forced treatment or involuntary treatment for individuals with a substance use disorder. I ask you to look at that attachment. It was prepared by the Public Health Law Clinic at the University of Maryland. Second, I do want to stress that Maryland does not have a comprehensive continuum of care adequate to meet the needs of those who actually want treatment. Thankfully, with the leadership of this committee, the state is increasing resources for the creation of mobile crisis teams, as you heard, and walk-in crisis service. You have also recognized the need to raise reimbursement rates, but treatment on demand does not exist yet. Instead, NCADD Maryland would rather see funding spent on number one, investing in a qualified workforce, including reimbursing certified peer recovery specialists, enacting more harm reduction strategies, including overdose prevention sites, expanding all the locally tailored crisis response services throughout the state, and increasing education and prevention strategies. Before we move down the path of involuntary or forced treatment, we urge continued investment into our community-based services for those who want it and certainly for those who need it. So for that, we urge an unfavorable report. And I thank you for this committee and all your hard work on this. And I thank all the family members for coming forth and talking about how difficult this is.
Thank you very much for your testimony today. Next, we have Ms. Carol McCabe. Good evening, Ms. McCabe. Will you please give us your testimony?
Yes, thank you, Madam Vice Chairman. I just want to.
I still have to listen. I can talk to you when this is over.
You please mute yourself if you're muted.
It's kind of like me
Thank
being
you
in
so
it.
much.
And I have to listen, okay?
Can you please mute yourself? Thank
It's
you.
for every witness. It's
Aaron Hopwood, we can hear you.
Aaron,
sorry. Oh my God.
go ahead, ma'am.
Sorry, Madam Vice Chairman. I just want to point out a couple of things. I submitted written testimony. I'm the chief of the Mental Health Division in the Public Defender's Office, and we represent 99.9% of individuals facing involuntary civil commitment in the state of Maryland. We're now representing clients in about 800 cases a month. The fiscal note, I think, severely underestimates the number of clients the Public Defender's Office will be representing, because their number is based on the number of emergency petitions that were filed in the district court, and they have a number of 3,799. Maryland law does not require emergency petitions to be filed with the district court, Police officers can draft emergency petitions. Mental health professionals can complete them and give them to police officers. So there are actually many thousands more emergency petitions filed in the state, and our clients are entitled to counsel when the emergency petition has been served and they're seized by the police. So that number's low. And additionally, there are severe collateral consequences that stem from an involuntary commitment in Maryland. And the Maryland Court of Appeals addressed those in a recent case. This is just to name a few: loss of driving privileges, prohibitions from engaging in a number of occupations, implications in child custody disputes, restrictions on immigration status. There are certain statutory reporting requirements, and hospitals are required to report individuals who are civilly committed because they're dangerous, lose their Second Amendment right to own or possess firearms. And so the hospitals are required to notify the FBI the names of the individuals who have been committed, when they were committed, the hospitals they were committed to. So that information no longer remains as confidential as it would be if people were going to a traditional drug treatment facility. So I just wanted to point out for consideration. Thank you.
Thank you for your testimony. Are there any questions for this panel? And I do not see any. So thank you very much for staying with us this late. I hope you have a blessed evening. This concludes our work for the day and concludes the hearing on House Bill 29.